आवाज करो ना पीछे प्लीज That's a request.
Good evening to each and everyone here. I am thrilled to welcome you all for today's webinar. ABG analysis must know in every year. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker, Dr. Navonil Dutta. Dr. Navonil has done MBBS, FIC, DNB, working since 2020. Served in the frontline critical care during COVID pandemic, teaching, moderating, and conducting seminars since 2022. He is also part of West Bengal Rheumatology Association and very regular to their CMEs and seminars organized across the country. During MBBS, he was part of SAMSA, which is South Asian Medical Student Association from 2017 to 2021. In 2019, he was awarded with the Best Poster Case Presentation at the International Undergraduate Conference ConScience 2029 in JIPMER Pondicherry. Over to you, Doctor.
Thank you. Thank you so much. Good evening to all of you who have joined in. Good evening to the team of Mediversal, and I wish you all a very, very, very happy New Year. Although it's been quite a few weeks that the New Year has commenced, but since this is my first webinar of the New Year, I am extremely thrilled and extremely grateful, extremely humbled to have all of you on this platform today. Thank you for the introduction, Vijay sir. And I'm sorry for a little delay that happened because of some technical issues. I'm currently not exactly in my place of residence, so I hope you'll be forgiving me for that. Well, today's topic has been something which I had been planning to take since last July. I mean, last year July, to be honest, because this is one area which I've always felt that as graduates who have just passed out or are doing their work as duty medical officers or rotatory medical officers, I've always felt this is one topic that keeps everyone on high alert. There is one topic which kind of creates a feeling of false stress. It's a stress alarm for many students, and I just wanted to get the cat out of the hat, as they say. So I'll be sharing my screen, and I'll be requesting you to be very interactive with me. That's what I'll be trying, and I hope we have a wonderful session together here. So I'll be sharing my screen. You'll be requiring to let me know whether. So in the first place, am I audible? Am I visible? That's the first thing that I'll ask you, because
Yes, doctor. You're loud.
yes.
You're loud and clear.
Okay, I'm loud and clear. Thank you. Thank you so much. Okay, so I'll be sharing my screen. Can you just let me know if this is visible?
Sure,
Just
sure.
a minute. Yeah, is this visible?
Yes, it is. It is.
Okay. Just a minute. So is everything visible here?
Yes, doctor, it is.
Fantastic. Okay. One honest request. I think every one of us are grown up enough to realize that when someone is presenting a webinar, silence is one thing that I think is a basic expectation. I've been, I wouldn't have said it this way if this was not a very regular happening, and it's not just with me. I've been finding so many senior doctors coming to this platform and presenting. Dr. Allen sir was presenting 2 days back. There was something very similar that happened here. I mean, I'm still okay. You can consider me a junior doctor enough, but Dr. Allen sir is someone who's been in this field for a very long time. I think every basic person who's presenting here deserves that minimum amount of respect. And I would abide you and request you with a very, very humble heart to keep up the integrity of yourselves, because I think the profession that we are in speaks a lot about what we are and what we are supposed to do. So I hope everyone behaves well in this webinar. I hope everyone interacts with me. That is always something that I've allowed. You can put up your questions. You can, challenge me on scenarios where you feel you have a different opinion. But please maintain the integrity of the forum. That's an honest request that I'm putting in. Okay. So before I start, can I just have a quick poll? This is something which I do always with you all. Can I have a quick poll to let me know how many of you are exactly MBBS graduates or practicing MBBS? How many of you are from other specialties, like if you're doing your specializations, or if you have completed your specializations, you'll of course be my seniors. And how many of you are from alternate methods of medicine, which are different from the modern methods of medicine? If I can get a quick poll on this quickly. Okay, I have answers. MBBS graduate, it's a BAMS graduate, MBBS. I'm currently not able to take all of your names because the speed at which the chat is moving. But hi, Dr. Rishika. It's a pleasure having you here. Thank you. I have a few known names. I'm not able to scan through everything, but please forgive me if I'm not able to take a few names. Okay, so yeah, I'll be starting off with the session. The reason why I have asked you about your respective statuses with respect to the profession is because it helps me understand the pace in which I would love to carry this discussion forward, and it also helps me interact with you on a very cheerful basis with respect to where you are. Okay, so before I start, something which I've always done, and I would love doing is paying a gratitude to the ones who have taught me. Uh, you all have been seeing their names quite often in every webinar that I've taken. Dr. Dilip sir happens to be an internal medicine faculty at Mehta Super Specialty Hospitals, Chennai, and Dr. Zainab Vora has been something which is more than just a teacher and a mentor to me. She has been someone who has absolutely strengthened me to be the person that I am, and trying to be better in whatever I try to do every single day. So she's one of the best radiologists that we have in this country from AIMS New Delhi. So before I start, it's always my humble gratitude to each one of them. And there's one more thing which I want to specify. Most of what I'm teaching you, most of what I'm presenting to you is a direct reflection, not even an indirect reflection. It's a direct reflection of what have been taught to me. I am just like a person who has tried modifying, tried altering a few things, tried presenting it in my way. But to be honest, the real lamp of light that has been lit has been by multiple other teachers, including the ones that you see on the screen at this point of time. So my heartfelt gratitude to each one of them and each one of my teachers who have paved the way for me to be today to be in this seminar, in this webinar. The moment we start with acid base analysis, there's a one particular thing which always keeps on booming our minds of the four terms of respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. And we really do not know what is happening. Only, I mean, as students of chemistry back in our 6th, 7th days, all we know is a lower pH is an acidotic pH, a higher pH is an alkalotic pH. But before we get the cat out of the hat, let us first talk about the normal ranges that we have. So whenever I'm talking of a normal pH, I'm talking of anything that is ranging between 7.35 to 7.45. 7.4 is what we take as an average. Whenever I talk of a normal PaCO2, it's something between 35 to 45 millimeters of mercury. And whenever I talk of normal bicarb levels, it is something that is between 22 to 28. We can take an average of 24, but that is basically the normal values that we have. So anytime I'll be referring to any EBGs, I've got multiple case reports, case scenarios that I've presented, some of them taken directly from my teachers, some of them shared by two of my friends, Dr. Rishika Bajaj and Dr. Debojyoti Devnath, both of whom I'll be thanking for sharing their in-hospital cases. Of course, I've hidden the patient identities for ethical reasons, but thank you so much for being so supportive and so kind and so helpful in this preparation that I've done today. So once we take ourselves through these case scenarios, this is one segment that I want you all to be very clear that the values have to be absolutely there in your head. 7.35 to 45 being the normal pH, 22 to 28 being the normal bicarbs, and 35 to 45 being our normal PCO2 levels. Now, we have this famous mnemonic called Rome. It's not my mnemonic. It's been an age-old mnemonic that whenever the pH and whenever the pH as well as the bicarb and PaCO2 values go in the same direction, then it's most likely a metabolic disorder. Whereas if the pH is in a different direction to the bicarb and the PaCO2 levels, it is most likely a respiratory disorder. So the first thing that we need to get out is Rome, that is respiratory meaning opposite, which means pH values or the arrows of pH, arrows as in increase or decrease in pH, will be completely opposite to the changes in bicarb and the PCO2 levels. And when I talk of metabolic disorders, the change in pH, increase or decrease, is going to be very synonymous and congruous with our bicarb and PCO2 levels. Let us just match it with this tabular form that we have. In the first case, if you find, are you all able to see my pointer? Can you just give me a quick thumbs up? Can you give me a quick thumbs up if my pointer is visible? Is my pointer visible?
Yes, doctor. Yes, it is visible.
It's visible. I hope my pointer is visible.
Yes, yes, yes.
Okay, fantastic. Okay, thank you. So in this first row of the table, we can find clearly that the pH is decreasing, and there is also a simultaneous decrease in bicarb and the PaCO2 levels, which means that the arrow of pH is always congruous or synonymous or in sync with the change in bicarb and PaCO2 levels. And as I said, metabolic is equal. So this is definitely a metabolic disorder. Whether it's an acidosis or alkalosis, we'll come to it later. In the second row, again, we have the similar thing. There's an increase in pH, and also simultaneously there's an increase in bicarb and a PaCO2 levels, which again means that the arrows of pH are very similar to the arrows of PaCO2 and HCO3 minus, which means again it's a metabolic disorder. The third row gives us a decrease in pH, and if you see that the change in bicarb and the change in PaCO2 are increasing, which means this is completely opposite to the change in pH, which makes it a respiratory disorder, similar to tab 4 or row 4, where you have an increase in pH with decreasing values of HCO3 and PaCO2, which means that the increase in pH is not in the same direction as HCO3 and as HCO3 and PaCO2 values are, which again makes it a respiratory disorder. Now, I hope this part is absolutely clear with you. So the very first thing, whenever you read an ABG analysis report, the very first thing that you need to see is whether the pH is increasing or decreasing. If it's a pH increasing, you definitely call it an alkalosis. If it's a pH decreasing, you call it an acidosis. That is something which even a 10th standard person will be able to say. But the one thing that differentiates respiratory from metabolic is whether the change in pH or the increase in pH is actually in the same line as PaCO2 and bicarb levels. So if PaCO2 and bicarb are also increasing with increase in pH, it's a metabolic disorder. If only pH is increasing but PaCO2 and bicarb are decreasing, then that's a respiratory disorder. I think that is the very, very, very basic part whenever we are trying to approach any ABG analysis, to be honest. Now, the one thing that I want to tell you is we have all been conditioned right from our first year MBBS or first, second years that the metabolic acidosis, if there's metabolic acidosis in a patient, the compensation is going to be a respiratory alkalosis. Whereas if there's a metabolic alkalosis in a patient, the compensation is going to be a respiratory acidosis, which means that whenever there is a metabolic disorder, be it acidosis or alkalosis, the compensation is always going to be through the respiratory route, that is by the lungs. Whereas on the other hand, if there's a respiratory disorder, be it respiratory acidosis or alkalosis, the compensation is going to be via the metabolic route, that is by the kidneys, because the kidneys are the prime driver of the metabolic functions and buffering system in the body. Now, the one thing that we need to be very, very clear of is the fact that respiratory compensation, which happens in settings of metabolic disorders, I repeat, in metabolic disorders, I say that there's a respiratory compensation. So this respiratory compensation actually starts very, very early, but it is a very ineffective compensation, which means that in the setting of a metabolic disorder, although the lungs try to compensate the change in pH at a very quicker rate, but it can never completely correct the pH, which means most of the times in clinical settings in metabolic disorders, you will never find the pH being normalized, no matter how much the lung is good, no matter how much well the lung is functioning, or no matter how much the lung is trying to compensate. I'm talking of acute metabolic disorder settings. Whereas in the setting of any respiratory disorder, be it alkalosis or an acidosis, I mean, whether it's a respiratory acidosis or alkalosis, as I said, the compensation is mainly by the kidney buffering system. The renal buffering system takes some while to set in, but once it has set in, it will almost always, because there's nothing called absolute in medicine. So there's almost always going to be a complete correction in the pH of the patient. So that is again something that we need to keep in mind. So 2 points till now, 2 takeaway points from this slide. One is ROME, that's respiratory is opposite, metabolic is equal, which means that the change in pH is very similar to the change in PaCO2 and bicarb. It's a metabolic disorder. If it's opposite, if they're opposite, then it's a respiratory disorder. Metabolic disorders are compensated early but ineffectively or impartially via the respiratory route, that's the lung, whereas the respiratory disorders are compensated late but almost very effectively and completely via the kidneys. Is this much clear to all of you? Is this much clear to all of you? Yes. Is this clear? Any doubts? You can quickly chip in your messages. My eyes are always on the chat box. I mean, in intervals, I'm checking on the chat box. I'll be taking very slow because I want you all to get done and dusted with this topic for once and all. So okay. So thank you for saying that you are clear with this. Okay. Now, uh, the one thing that we are very sure of, that in the first slide, in this first table, where the pH is reducing and the HCO3 minus is reducing and the PaCO2 is also reducing, one thing that we are very sure is it is a metabolic disorder and it's an acidosis. Why am I calling it an acidosis? Because the serum bicarb levels are very, very low. So because the bicarb is low, which means that the body is losing bicarb, that is why the serum bicarb levels being low makes the body have an acidotic pH, right? Or whereas on the other hand, in the second tab, we have serum bicarb levels to be very high, which means that the body is not able to lose bicarb. The body is not able to lose bicarb, which means it is retaining bicarbonate ions, which is definitely leading to an increase in the serum bicarb levels and thereby causing something which is called as the metabolic alkalosis. Correct. When I talk of the third slide, the acidosis that we are finding in this is definitely due to the increase in the PCO2 levels, because the PCO2 CO2 is definitely an acid in the body, and we know that CO2 being an acid, it will contribute to the acidic fraction, and whenever there's an increase in PaCO2, it will lead to respiratory acidosis. Whenever there's a decrease in PaCO2, it is going to lead to respiratory alkalosis. I think all of this should be very, very clear. Now, in the first tab of metabolic acidosis, because the patient is losing bicarb through the body will try to compensate it by hyperventilation. The body will try to compensate it by hyperventilation. And who is going to play a role in this? The lungs are going to play a role in this. So in metabolic acidosis, the compensation is very quickly started by the lungs. The lungs start to create a mechanism in which the body starts hyperventilating. And we know that whenever we are hyperventilating, there is a CO2 washout that is happening, which is leading to a reduction in the levels of PaCO2. In metabolic alkalosis, there's a relative hypoventilation that we get, which leads to an increase in the PaCO2 levels. In respiratory acidosis, which is the third tab in this table, we have an increase in the PaCO2 levels. So the body will try to, the kidney rather will try to, reduce the urinary bicarbonate levels. It will start to reduce the excretion of bicarb through the urine, which will make the serum bicarb levels go up. And in the fourth case, that is a respiratory alkalosis, what happens is the body increases the levels of urinary bicarb ions. So that is exactly how the compensatory mechanisms set in. Now, whenever I talk of respiratory acidosis, this is something which I expect you all to know, but I'll still be mentioning it. From the pulmonology point of view, when I talk of respiratory acidosis, anytime there's a respiratory component with a PaCO2 that is high, that is a respiratory acidosis, we typically call it a type 2 respiratory failure. We call it a type 2 respiratory failure. And whenever there is the setting of a respiratory component with a normal PaCO2 levels, depending on whether the PaO2 may be normal, it may be low, that just doesn't matter. But PaCO2 being normal just makes it a type 1 respiratory failure. I'm repeating this again. In the setting of any respiratory condition, if the PaCO2 levels are high, it is called a type 2 respiratory failure. If the PaCO2 levels are normal, it's called a type 1 respiratory failure. That should be it. So finally, we are reaching to the end of this slide, where we are trying to discuss what the next step is.
Doctor, sorry to interrupt. Can you please make the screen full screen?
How to make this? Just a minute.
Can you see an orange play button down?
Orange play button down.
Next to it. Next to that button. Yeah.
This?
Yeah.
No. Wait, I think I can do something. Is this better?
Perfect, perfect.
Is this better?
Perfect,
Perfect?
perfect, perfect. Thank you
Yeah,
so much.
good enough. Yeah, yeah. Okay.
Sorry,
So,
sorry for the
no, no,
interruption.
not an issue. Not an issue. Absolutely. Okay. So, where was I? Yeah. So I was talking of this thing that wherever we are dealing. Once we have come down to the narrowing of what disorder it is, our next step is to see if it's a metabolic disorder. Our first thing that we need to keep in mind is the Winter's formula and to check out the Anand gap. If it's a respiratory disorder, our next step is to check an AA gradient. What is an AA gradient? It's an alveolo-arterial gradient. That's the PaO2. P capital AO2 means the partial pressure of oxygen in the alveoli minus P small AO2, which is the partial pressure of oxygen in the lungs, in the arteries. Which means that once we have a respiratory component, our next step is to check the AA gradient. Once we have a metabolic component, our next step is to check the Winter's formula. So we'll start with the metabolic components of ABG analysis with the hope that this slide is completely clear to you. One more thing which I want to end this slide with is if the arrows, that is HCO3 minus and PaCO2, if they move in opposite direction, just close your eyes and know it's a metabolic, it's a mixed metabolic disorder. By this, I mean, can you just clearly see the 4 tabs that I've shared here in this table? All of this has one thing in common. No matter what the pH is, whether it is decreasing or increasing, the HCO3 and the PaCO2 are always in the same direction. See here in the first tab, HCO3 minus is low, PaCO2 is low. HCO3 in the second tab, HCO3 minus is high, PaCO2 is high. In the third tab, again, they are all in the same direction. But the moment you find in an ABG that the HCO3 minus is decreasing and the PaCO2 is increasing, or vice versa, if the arrows of HCO3 minus and PaCO2 are changed or reversed, close your eyes and know it's a mixed metabolic disorder, which means there are almost 2 or 3 components inside this ABG analysis. I think that should be clear to all of you. Okay, now we'll be gradually moving in for our next step for metabolic disorders. As I said, we'll be checking Winter's formula and we'll be checking the Anand gap. Okay, now this is one thing that I want you to write up. This is one of the reasons why I did not write this in the slide. What is exactly the Winter's formula? So in Winter's formula, the Winter's formula, I repeat, number 1 is only for metabolic disorders. I'm saying this, I'm telling all of you to write this down because this is actually going to stay in your head more if you write it down. And if you follow what I'm saying, the next time that you see an ABG with a metabolic disorder, there are basically 4 steps that you need to see in algorithm. And once you are sorted and done and dusted with those 4 steps, trust me, ABG is just a piece of cake. So for metabolic disorders, only for metabolic disorders, be it metabolic acidosis or alkalosis, our next step is to check out the Winter's formula. Now, whenever there's a metabolic disorder, what do we know? That the compensation is basically by the lungs. And depending on whether it's a metabolic acidosis or an alkalosis, the PaCO2 levels are going to rise or fall, right? That's what we know till now from our discussion as of now. So in a setting of metabolic disorders, let us take for a setting of metabolic acidosis, and I want you to write this down. Whenever there's a metabolic acidosis that is happening, we need to check what is the expected PaCO2 level that is required to compensate that. So we are actually through Winter's formula trying to understand what is the expected PaCO2 levels that will be required to compensate the metabolic disorder that is occurring in the patient. In case of a metabolic acidosis, what do we know? In case of metabolic acidosis, the PaCO2 levels have to go down, which means the lungs have to start hyperventilating. Now, how much should the PaCO2 go down? That is described by the Winter's formula. So for metabolic acidosis, it is 1.5 times the serum bicarbonate plus 8. I repeat, it's 1.5 times the serum bicarbonate plus 8. I want you all to write this down because when you write it, a part of our cognition is also receiving a different sensory modality that we can keep in our head. So for metabolic components, mainly metabolic acidosis, the expected PaCO2 that we should get is 1.5 into serum bicarbonate levels. That bicarbonate levels will be given in the ABG report plus 8. Now, whatever this value is, add a plus minus 2 to this value. That is the range. I'll be taking you to a slide. I'll be taking you to a slide and we'll be discussing this right away. So let us focus on slide on example number 1. On example number 1, I'm opening the chat box for all of you to say. Just give me a moment. Can you all check example number 1? Can you all write in the chat box because I'm able to see the chat box right now. What is the pH? Is it low or is it high? Is it low? Is it high? I'm sorry, I'll not be able to take names, but because I'm not able to see, yes, it is a low pH, which means there's an acidosis which is happening. Okay, first, whenever there's a low pH, it's acidosis. Now, can you tell me whether the bicarb and the PaCO2 are moving in the same direction or not? Is the bicarb low or is the bicarb high? Is the bicarb low or high? Yes, the bicarb is low. Is the PaCO2 low or high? Is the PaCO2 low or high? Yes, it is low. Fantastic. So can I say that the pH arrow, the arrow of pH is absolutely in the same direction as the arrow of bicarb and PaCO2? Perfect. Which makes it a metabolic disorder. By Rome criteria, we know metabolic means equal. So it is a metabolic disorder. And because the pH is low, we can call it a metabolic acidosis. Is everyone clear with this? Is everyone clear with this? The first example, it's a metabolic acidosis. Is everyone clear with why it is metabolic acidosis? Anyone who has not understood why this is metabolic acidosis? Anyone who's not understood why this is metabolic acidosis? Our first focus is to check the Rome criteria. No, sir. Who's Dr. Arfa? I'll be repeating this for you. So our first target is to check the Rome criteria. In Rome criteria, we know that the change in pH, the arrows of pH has to be very similar to the arrows of PaCO2 and HCO3, which is indeed this in example 1, which makes it a metabolic disorder. Hence, and because the pH is low, we can call it an acidotic pH. So metabolic acidosis is a diagnosis. Is everyone clear with this? Is everyone clear with this? Okay, fantastic. Thank you, Dr. Alpha. Okay, now once there's a metabolic acidosis, what do we know as the compensatory mechanism? Who is going to compensate a metabolic disorder, lung or the kidney? Who's going to compensate a metabolic disorder, lung or the kidney? It's a lung. Very good. It's the lung who's going to compensate. And what will be the compensation that the lung will try to do in a metabolic acidosis? Will it try to hyperventilate or hypoventilate? Will it try to hyperventilate or hypoventilate? Hyperventilate. Very good. So once the lung tries to hyperventilate, yes, very good. So once the lung tries to hyperventilate, we should get a low PaCO2 levels, right? We should get a low PaCO2 levels. But here in this ABG, we're already getting a low PaCO2. But is it sufficient enough? It's like our parents coming and telling us ki beta achhe se padho, study hard, and we are like, ha papa mummy, we are studying hard, maybe 2 hours 3 hours a day. But maybe when it is just 2 days before the exam, 2-3 hours a day are not enough to study. Maybe we need to give in more. So yes, we are studying for 2 to 3 hours a day, but do you think it is adequate enough just 2 days before the exam? Definitely not, right? That is one time when you'll be looking to click 9 hours, 10 hours, 11 hours, or maybe more than 12 hours a day. So we have to check that despite the PaCO2 levels being low in the ABG, is this PaCO2 low enough to be compensating for the metabolic cause? How do we do it? We check the expected PaCO2 levels by Winter's formula. And what is the formula that I told you for metabolic acidosis? What is the formula that I told you? It is 1.5 into serum bicarb plus 8. Can you tell me what is the number that you'll get once you'll be doing this mathematics? I know we doctors do not love to do mathematics for quite a long while, but it's a very short calculation. 1.5 times serum bicarb plus 8. What is the serum bicarb? It is 14. So 1.5 into 14 plus 8 gives me around 29. Correct. And I told you, in case of metabolic acidosis, you need to do a plus minus 2, which means that the range becomes 27 to 31. Am I correct? Can I say this? That the range is between 27 to 31. Yes, indeed, it's 29, but then we need to do a plus minus 2. So it makes the range 27 to 31. Is everyone clear why the range is 27 to 31? Fantastic. So now that we know that the range should be expectedly between 27 to 31, what is the PaCO2 levels that we are getting in this case? It's 28. Is it falling in the range or out of the range? Is it falling in the range or out of the range? Yes, in the range. So can I say that the compensation has been adequately tried by the lungs? Can I say that the lungs have tried to adequately compensate? Can I say that the lungs have tried to adequately compensate? Can I say that the lungs have tried to adequately compensate because my expected PaCO2 is absolutely in the range which it should be for the bicarb levels that we are having? Yes. But did I also not tell you that the lung compensation starts early, but it is very ineffective? Why do I say ineffective? It will never be able to normalize the pH. Therefore, do you see, despite the lungs hyperventilating and trying to create a PaCO2 which is low, it is still not able to correct the pH. Your patient is still having a grossly reduced pH. The patient is still in metabolic acidosis. Can I say that? Can I say that? Fantastic. So the diagnosis of this ABG report becomes a metabolic acidosis with a compensatory respiratory alkalosis. The lung is trying to compensate, so there's a compensatory respiratory alkalosis. Is this clear? Is this clear? Correct. Now, can everyone focus on example number 2? Can everyone focus on example number 2? Can you tell me what is the primary disorder? What is the primary disorder? Do not tell me the entire analysis of the ABG. Just tell me what is the primary disorder. Is it a metabolic disorder? Is it a respiratory disorder? What is it? Okay, it's a metabolic disorder. And you're saying that it's a metabolic disorder because the arrows move in the same direction. Very good. So it is a metabolic disorder. Is it an acidosis or alkalosis? Yes, it's an acidosis. So it's a metabolic acidosis. Very good. Now, whenever there's a metabolic acidosis, the compensation should be respiratory alkalosis, right? And in the case of a metabolic acidosis, our next step is to check for Winter's formula. What is the Winter's formula for expected PaCO2 in case of metabolic acidosis? 1.5 times bicarb plus 8. What is the value again? 1 point that, see, I've kept the bicarb level same so that the calculation becomes easy. So the last time we calculated 27 to 31 has to be our range. What is the PaCO2 here? Is it in the range or out of the range? Is it in the range or out of the range? Is it in the range or out of the range? It is out of the range. Is it higher than expected or lower than expected? Is it higher than expected or lower than expected? It is higher than expected, which means though according to the ABG, PaCO2 levels are low, but it is still higher than what the compensatory mechanisms should have done, which means whenever there's a high PaCO2, what do you call it? Do you call it respiratory acidosis or alkalosis? Do you call it respiratory acidosis or alkalosis? Whenever there's a higher PaCO2 than expected, do you call it respiratory acidosis or alkalosis? Very good. It's a respiratory acidosis. So can I say therefore that this ABG is basically, the diagnosis of this ABG is a metabolic acidosis with a respiratory acidosis. Can I say that? Can I say that? Who? Okay, somebody wrote alkalosis. I'm not able to read your name, but I hope you're clear with what I'm saying. See, my dear, despite the ABG showing a low PaCO2, despite the ABG showing you a low PaCO2 levels, what is actually happening is the expected PaCO2 is supposed to be in the range of 27 to 31, but my ABG is showing a PaCO2 35, which means it's higher than the expected PaCO2. And whenever there's more CO2 in the body, we call it an acid. So it's a respiratory acidosis along with the setting of a metabolic alkalosis. Is this clear? Is this clear? Can we move on to the third example? Can we move on to the third example? Yes, it's a mixed acidosis. Absolutely, it's a mixed acidosis. Okay, can we move on to the third example? In the third example now, can you please tell me what is it? What is the primary diagnosis? Primary diagnosis. What is the primary disorder? Yes, it is metabolic. What is it? Is it acidosis, alkalosis? What is it? What is it? Is it a acidosis? Is it an alkalosis? Quickly, everyone. Everyone. Yes, it is metabolic acidosis. The pH is 7.33. It is low, and we are also having a low bicarb levels, and the PaCO2 levels are also low, which makes it indeed a metabolic acidosis. What is our next step to check in metabolic acidosis? It is Winter's formula. So again, 1.5 times bicarb plus 8. Again, the range is 27 to 31. But what is the PaCO2? It is lower than the range. Is everyone clear? It is lower than the expected range. Can I say that? The PaCO2 is 17, which is lower than what the expected compensation should be. Very good. Whenever there's a lower PaCO2 than expected, what do we call it? Respiratory acidosis or alkalosis? Whenever there's a Yes, it is a respiratory alkalosis. Yes, it is a respiratory alkalosis. So again, this is a mixed ABG showing metabolic acidosis with respiratory alkalosis. Is everyone clear? Now, let me tell you the background of this patient. This patient was actually a patient of salicylate poisoning. So what salicylate does is, whenever there is more amount of aspirin, I mean aspirin or salicylate poisoning, it completely depresses the it completely drives the respiratory center to a point that you start hyperventilating so high. You start hyperventilating to an extent that the PaCO2 levels become very low, almost undetectable in your body. I mean, 17 PaCO2 is an extremely low PaCO2 level in the body. So it is due to aspirin or salicylate, which triggers the respiratory center and sets off a rapid or a racing hyperventilating response. Okay, so this was a patient of aspirin or salicylate poisoning that had presented to the ICU. So the diagnosis of this again is a metabolic acidosis with respiratory alkalosis. Okay. Can you tell me something? Let's not do example 4 right now. I want you to focus on example 5. I want you to focus on example 5. What is example 5? I think the easiest diagnosis of all is example 5. What is example 5? Everyone just saying metabolic. Everyone just saying metabolic. Please note that I clearly said something. Yes, I finally found a correct answer. That is by Bonville. Okay. I know who Bonville is. Hi, Dr. Imjim. Thank you. Thank you for joining in. Yes, it's a mixed disorder. I clearly said in the first place that the moment you find, so example 5, you have a pH which is 7.20. So the pH is low, right? But check for bicarb and PaCO2. Bicarb is low, but PaCO2 is high. The moment bicarb and PaCO2 are having opposite arrows, close your eyes and know that it's a mixed acid-base disorder. Is that clear? It's a mixed acid-base disorder. I'm repeating. See, our Rome criteria was considering the fact that the arrows of pH change will be synonymous or opposite to the arrows changes of PHCO2 and HCO3, which means hamesha in our body, HCO3 and PaCO2 have to follow the same arrows. Either they'll increase together or they decrease together. The moment I have an ABG analysis where HCO3 and PaCO2 are incongruous or they are in opposite directions, maybe HCO3, in this case HCO3 is low, PaCO2 is high. The moment this is the ABG scenario, close your eyes and know that this is a mixed ABG disorder. Is that clear? Now, what disorder is it? Indeed, it's a mixed metabolic and a respiratory acidosis. The PaCO2 levels are high, HCO3 minus levels are low. So both of them are contributing to the acidosis. It's a mixed respiratory and metabolic acidosis. Is everything clear? Is this clear? Everyone's clear with this example 5? Everyone's clear with example 5? Okay, fantastic. Okay, now let's talk of metabolic alkalosis. So we talked of metabolic acidosis. I'll be switching myself back to the older slide. Yeah. So we talked of metabolic acidosis. Now we'll be talking of metabolic alkalosis. Whenever I talk of metabolic alkalosis, what did I already say? That whenever there's metabolic alkalosis, the body will try to compensate it by the lungs increasing the PaCO2 levels, which means there'll be a relative alveolar hypoventilation. जिससे क्या होगा? PaCO2 levels are going to increase. Correct. Whenever there's a metabolic disorder, what is our next step? It is indeed to find out the Winter's formula. And by Winter's formula, I want you to write this formula now. For metabolic alkalosis, abhi tak we were doing Winter's formula for metabolic acidosis. So for Winter's formula for metabolic alkalosis, in fact, this is the only last formula that I'll try to burden you with, maybe one or two here and there, but I won't put you into much of burdens through calculations. I know we hate maths altogether. So metabolic alkalosis mein, what is the expected PaCO2? It is 0.7 into bicarb, 0.7 into bicarb plus 20. 0.7 into bicarb plus 20. But unlike metabolic acidosis, where we were keeping a range of plus minus 2, in case of metabolic alkalosis, we'll keep the range as plus minus 5. Is that okay with everyone? So I repeat, Winter's formula for metabolic acidosis is expected PaCO2 equal to 1.5 into serum bicarb plus 8 plus minus 2. Expected PaCO2 for metabolic alkalosis according to Winter's formula is 0.7 into serum bicarb plus 20 plus minus 5. Is this clear with everyone? Is this clear with everyone? I'll be again moving on to the slide, which is the examples. Yeah, this is the slide. Is this clear with everyone? Are you clear with the formula for metabolic alkalosis? Is my voice breaking? You want me to explain the case scenario where mixed metabolic alkalosis and acidosis have occurred? Which one do you want me to explain, Dr. Rimjim? Okay, you want me to explain case scenarios where both mixed metabolic acidosis and alkalosis can occur. Yes, I think I have a case with me here itself in the presentation, which I'll be talking of. Okay. Yes, we have a lot of real life case scenarios. I'll be taking you through that. And of course, there are a few which I have presented in this case. So I'll be trying to show that to you. In case I miss out on anything, we can always, I can always bring in more examples. I'm already running a case series channel on this Mediversal platform which is there on Instagram, and I'll be trying to add multiple ABGs. In fact, that is what I've been thinking. Once this webinar gets over, the next month I'll be dedicating to ABG analysis and case scenarios related to ABGs. I think that should be fine. Okay, so formula. Okay, you want me to repeat the formula for metabolic alkalosis? For metabolic alkalosis, the expected PaCO2 is 0.7 into serum bicarb plus 20 plus minus 5. 0.7 into serum bicarb into 20 plus minus 5. Okay, there's someone who writes 0.9 into serum bicarb. Yes, you can do a 0.9 into serum bicarb as well, but then the addition will not be with 20. It will be with 16. So because I want it to be a little closer to whole numbers, which is why I said 0.7 into bicarb plus 20. You can take that. Ultimately, the calculation will be the same. 0.7 into bicarb plus 20 plus minus 5. Is that okay? Okay. Okay. Now, I hope everyone's written the formulas. We can go to example number 4. Can we do example number 4 together? So, gear up. Example number 4. Can you tell me, what is the primary diagnosis? I think I've repeated the formula quite a number of times now. 0.7 into serum bicarb plus 20 plus minus 5. 0.7 into bicarb plus 20, that's the formula. And you have a plus minus 5 for metabolic alkalosis for the range. Can we go to example 4? Everyone who's written the formulas, can we focus on example 4? Can you please tell me what is the primary disorder in example 4? Okay, somebody writes mixed alkalosis. Sorry, it's not mixed alkalosis. Okay, metabolic alkalosis, yes. Why are you just writing respiratory? What? See, my dear, there's nothing called respiratory. What is it? Respiratory what? Okay, I'm getting a lot of correct answer. That's metabolic alkalosis indeed. So the first thing that we see is pH is increasing, and it is congruous to the increase in bicarb, because bicarb is 34, it is high. PaCO2 is also high, which means that the increase in pH is in congruence or sync with the increase in bicarb and PaCO2, which means according to Rome criteria, it has to be a metabolic disorder. Because the pH is high, it is a metabolic alkalosis. Till now, everyone is clear. It's a metabolic alkalosis. Everyone's clear. Is everyone in agreement with me that it is a metabolic alkalosis? Great. So once it is a metabolic alkalosis, what was my next step for any metabolic disorder? My next step is to see the Winter's formula. And in Winter's formula for metabolic alkalosis, what is my expected PaCO2? It is 0.7 into serum bicarb plus 20. So 0.7 into 34 plus 20. Can anyone help me with the mathematics? 0.7 into 34 plus 20. Kitna hota hai? It is around 44. If I'm not wrong, it's around 44. Yeah, it's 44. Okay. And because we know that there is always going to be a plus minus 5. So 44 plus minus 5 makes it, the range becomes 39 to 49. Is everyone clear? 39 to 49 is our range. 39 to 49 is our range. Yes, yes, very good. Yes, once it is 39 to 49, what is our PaCO2 levels now? Is it in the range? Is it out of the range? Is it in the range? Is it out of the range? Is our expected PaCO2 levels in the range or out of the range? How is it out of the range, my dear? 39 to 49 is the range. 45 is the PaCO2 in the. Please check the values, my dear. See, I'm repeating this explanation for this example. You're having a metabolic alkalosis. This much is sure, because why is it alkalosis? Because the pH is high. Why is it metabolic? Because the arrows of pH are incongruent with the arrows of PaCO2 and HCO3 minus, which means it's a metabolic disorder, right? Now, in a metabolic alkalosis, our next step is to check for Venter's formula. In Venter's formula for metabolic acid alkalosis is 0.7 into serum bicarb plus 20. That gives me 44 plus minus 5. Because for metabolic alkalosis, it's plus minus 5. It means that the range is between 39 to 49. And my PaCO2 here is 45. Can I say that because my PaCO2 is in the expected range, can I say that there has been an adequate hypoventilation by the lungs? Can I say that the lungs have adequately hypoventilated? Can I say that the lungs have adequately hypoventilated? Can I say that the lungs have been adequately hypoventilating? No. Somebody is saying no. Somebody with a username of everywhere. What exactly is the problem that you're encountering, my dear? I'd be loving to address it. What exactly is the issue that you are undergoing? My expected range was 39 to 49. My PaCO2 is 45. It is in the range, which means that the lungs are adequately hypoventilating. Therefore, my diagnosis becomes a case of metabolic alkalosis with a compensatory respiratory acidosis. Metabolic alkalosis with a compensatory respiratory acidosis. Can I say that? Is this clear with everyone? Is this clear with everyone? Okay. Now, since this part is clear, why pH is not falling in normal range if the compensation is adequate? Oh my dear, oh my god. Okay, Dr. Dr. Giriraj, is that your name? Okay, my dear, I clearly told you that in metabolic disorders. Okay, is there anyone who will be replying to this question? I'll be actually happy if someone can reply to an answer to Dr. Giriraj as why pH is not normal if the compensation is adequate. Can someone who has already been answering till now answer this? Exactly. So Dr. Rimjim has answered this, that the lung compensation is never adequate. It starts off early, but it is always inadequate. It cannot correct the pH. Lung compensation in itself can never correct the pH. That is why, despite the lungs trying to compensate, the pH is never normal. Okay, is that clear? Once you start dealing with respiratory problems, my dear, where you will see the compensation is by the kidneys, you will actually try seeing how beautifully the kidneys have compensated it. And I'll be taking you gradually to this right now. Can you please try checking? Can you please try checking example number 6 for me? Yeah. Can you please try checking example number 6 for me? Giriraj, let me start it off with you. Dr. Giriraj, let me start it off with you. Okay, I'm not pointing anyone. I'm just trying to make you all better. I'm trying to get better in the process of making all of you better, and we can all, become better people and better humans and better doctors, I believe. So, example number 6. Giriraj, you can join with me in this. Yes. Example number 6. Yes, Giriraj, I'm so happy with you. It is respiratory component. Definitely it's respiratory because the change in pH is not coinciding with the same change in the HCO3 and PaCO2. यानी कि PaCO2 बढ़ रहा है, bicarb बढ़ रहा है, but pH is low, which means it is opposite in direction. So the primary problem is a respiratory problem. Itna is very, very good. Respiratory acidosis is our diagnosis. Very, very good. Now, can you tell me something? Is the PaCO2 high or is the PaCO2 low? Is the PaCO2 high or is the PaCO2 low? When the PaCO2 is high in the setting of a respiratory disorder, be it alkalosis or acidosis, what did I say? That what do we call this type of respiratory failure? Type 1 respiratory failure or type 2 respiratory failure? Whenever in the setting of a respiratory ABG background, where we have a PaCO2 which is high, yes, we call it a type 2 respiratory failure. Indeed, it's a type 2 respiratory failure. Can you give me a real life case scenario of a type 2 respiratory failure? A real life case scenario of a type 2 respiratory failure. Yes, it is COPD. Yes, it is COPD. Any obstructive lung disease which is coming to us in an acute exacerbation, any obstructive lung disease which is coming to us in an acute exacerbation will definitely lead to a type 2 respiratory failure. Very, very, very good. I'm so happy with all of you. Thank you. Thank you so much. And now I'll be telling you the one thing which is a lacuna till what I have discussed. So I clearly said whenever there's a respiratory disorder, which is the primary disorder, the compensation is mainly by the kidneys, right? The compensation is by the kidneys. Everyone agrees to it. Whenever there's a primary respiratory problem, the compensation is usually done by the kidneys. Everyone is clear with this? Yes. But what did I say? The kidneys can start compensation early or late. Do they start compensation? Do they start compensating very early? Or do they take some time to start compensation? Yes, it takes some time to start compensation. Do you therefore see that any patient of type 2 respiratory failure will present to you in the OPD or in the ICU? Can you please tell me, any patient of type 2 respiratory failure, any exacerbation of COPD, any exacerbation of bronchial asthma, which is presenting to you as a type 2 respiratory failure, will this patient walk to you or will this patient come in the ICU? In the ICU, which means it's an acute setting. Do you think that the kidneys can compensate it in such a small while? Do you think that the kidneys can compensate it in such a long while? No, it cannot. Fantastic. Therefore, do you see that the pH is still grossly reduced because the kidneys are not able to compensate it? The kidneys are not able to compensate this change. Is this clear? Is this clear? So one thing that I'll be adding on to my discussion as to whatever I've said till now, in the setting of a respiratory acidosis, if you see that the serum bicarb levels are less than 30, know that it is an acute problem. I'm repeating, in the setting of a respiratory acidosis, if you see that the serum bicarb levels are less than 30, know that it is an acute respiratory acidosis. It's an acute respiratory acidosis. What is the bicarb levels here? It's 26, which clearly means that the kidneys have not been able to compensate. Is this clear? Is example 6 clear? I'll be repeating example 6 once more. We have respiratory as our primary component because pH is decreasing, but bicarb and PaCO2 are increasing. So the arrows are opposite. Rome means respiratory is opposite. So it's respiratory, pH is low. So it's respiratory acidosis. Once it is respiratory acidosis, we find that the compensation and I mean the PaCO2 is high, which means it makes it a type 2 respiratory failure. Examples of real life case scenarios of type 2 respiratory failure means exacerbation of any obstructive lung disease, be it exacerbation of COPD, bronchial asthma, bronchitis, anything of that sort is a type 2 respiratory failure. And in a setting of a type 2 respiratory failure, the patient will definitely walk, not walk to us in the OP, they'll come in a stretcher, breathless, in the middle of the night in an acute setting. We know that in an acute setting, for a respiratory primary problem, the kidneys are not, they are not efficient enough to start compensating early. Yes, they will start compensating and they'll compensate very well, but in the later stages, jitna jaldi ek acute exacerbation of COPD present karta hai, the kidneys cannot start compensating early, which is very well reflected in the pH that we are having. The pH is very, very low. It's 7.21, which means the kidneys have not even started to compensate. In the setting of a respiratory acidosis, what is the compensatory response that you expect? You expect the kidneys to absorb bicarbonate, to reabsorb bicarbonate, right? So that there's alkalosis. But because the kidneys have not yet started to reabsorb bicarb, you will find that the bicarb levels are less than 30. I repeat, Dr. Giriraj, this is what you were wanting me to repeat. In the setting of an acute respiratory acidosis, how do you know that the respiratory acidosis is acute or chronic? Whenever in the setting of a respiratory acidosis, you have a bicarb level less than 30, know that the kidneys have not yet started to work, which makes it a very acute presentation. Is this clear, Dr. Giriraj? Is this clear? Okay, it was not Giriraj. I think it was someone else. Dr. Krupa's iPhone. Okay, Dr. Krupa, is this clear to you now? Am I clear to you? Everyone's clear with what I said. In the setting of a respiratory acidosis, if your bicarb is less than 30, know that it is an acute respiratory acidosis. Is this clear? In the setting of a respiratory acidosis, if your bicarb is less than 30, know that it is a acute respiratory acidosis. Okay, now let us focus quickly on example number 7. Example number 7. Everyone, I want all of your eyes and attention very closely on example number 7. I want you all to tell me what is the primary diagnosis. What is the primary diagnosis? Chronic respiratory. Yes, yes. This is said by Dr. Supriya. Thank you. Thank you so much for giving such a wonderful answer. Okay, everyone, can we start the discussion for example number 7? So example number 7, the pH is okay, mota, okay, 7.35 to 7.45 is the actual pH. If I judge by the as a borderline value, I can still say that, okay, it's a little low. My bicarb is high, PaCO2 is high, which makes it a respiratory component. PaCO2 is high, which makes it a type 2 respiratory failure. But see how beautifully the kidneys have compensated. Why? Because the bicarb has gone to more than 30. As I said, in a respiratory acidosis, if the bicarb is more than 30, it is a chronic respiratory acidosis. And in the chronic state, what happens is the kidneys start compensating so well that it has brought back the pH to an almost near normal pH of 7.36. Is this clear? Is this clear with everyone? First of all, why respiratory acidosis? Is this clear? Second, why chronic respiratory acidosis? Is this clear? Is this clear to everyone? Can I expect a wholehearted response from you all? Thank you. Thank you so much. Now, what is example number 8? This is one of the best questions that we have. Okay. Anyone who can answer example number 8, except Dr. Rimjim, will be getting a chocolate. Why except Dr. Rimjim? Because she knows this case. Hence, example number 8. I want you all to be very, very attentive. Example number 8. I want you all to take some time. You're rushing off with the diagnosis. Please don't rush off with the diagnosis. Please don't rush off. Please don't rush off. Yes, it is. Yes, it is respiratory acidosis. I'm not doubting that. I'm asking you, what is the presentation of this patient? Is it acute? Is it chronic? Okay, somebody has said chronic. Yeah, that is what I want to know. Is it acute or is it chronic? I've got one answer. It's chronic, chronic, chronic. Sabhi koi chronic bata raha hai. Everyone is saying chronic. Everyone is saying chronic. Very good. Now, everyone who is written chronic, pause for a while. Close your eyes. Keep your hands, keep your palms on your eyes. आंख बंद करो 5 सेकंड के लिए. 5 सेकंड साइलेंस. नो टाइपिंग, नो सीइंग द स्क्रीन. मैं कुछ नहीं बोल रहा हूं. जस्ट क्लोज योर आईज. धीरे से बोल रहा हूं. ध्यान से सुनो. If it was a chronic respiratory acidosis, the compensation would have been by the kidneys, and the kidneys would have been adequately able to correct the pH, right or wrong. इतना बता दो कि अगर ये chronic respiratory acidosis होता, अगर chronic होता, तो the kidneys would have been able to compensate the response, and it would have been able to bring the pH to a near normal pH. pH कितना गंदा है अभी देखो, 7.21, such a low pH. Do you think that this is a chronic respiratory acidosis? See, we have an example of chronic respiratory acidosis, that is example number 7. But example number 8, do you think this is chronic respiratory acidosis? Somebody is now saying acute. Of course, if it's not chronic, it will be acute. But no, it is not acute as well. It is not acute as well. Thoda socho. See, you are saying chronic because bicarb is more than 30, right? First tell me. Hello. You are saying chronic because bicarb is more than 30, right? Correct? Correct. Okay. Now, you also know this ki haan, bicarb is more than 30. Dr. Navonil told us ki, yaar, in the setting of respiratory acidosis, agar bicarb more than 30 hai, to chronic hai. Very good. But Navonil also told you that in a setting of chronic respiratory acidosis, the pH would be balanced. But pH balance nahi hua hai. Then what the hell is wrong? What the hell is wrong? Please see the PaCO2. Please see the PaCO2. Is it just high or is it grossly high? Is it just high or is it grossly high? No, there's no sample error. Sorry, these are real life case scenarios. These are not sample errors. It is grossly high. Therefore, because see example 7, where there was a chronic respiratory acidosis. PCO2 was raised, but it was not this high. PCO2 was raised, but this was not this high. So this is actually the presentation of acute on chronic respiratory acidosis. This is actually the example of acute on chronic respiratory acidosis, which means that example 7 was actually the baseline value of this patient. Now, say any patient of, say, COPD has now undergone pneumonia. We know that COPD patients are at a risk of pneumonias, right? They're at a very high risk of infections. Everyone agrees to this? COPD patients are at a very high risk of pneumonias due to stagnation of secretions, unable to expectorate those secretions. Everyone's clear with this? So now when this guy who is having a baseline ABG of example 7, which means he's a known case of a chronic COPD. Chronic COPD ठीक ठाक मेंटेन कर रहा है, अचानक अभी changing seasons hai, gets a pneumonia or a lung infection. Do you realize that this will be an acute exacerbation of a chronic COPD patient? Because of the chronic COPD, the kidneys will be compensating the bicarb, but because of the acute setting, they cannot work anymore to correct the pH. Is this clear? See, in this case, I'm telling you a very simple scenario. This patient is already a type 2 respiratory failure patient. Yani ki he cannot breathe fast. ऊपर से हुआ है infection. Whenever there is an infection that has occurred in this patient, what has actually happened? In a type 2 respiratory failure, whenever there's an underlying infection that has occurred, this patient has further deteriorated. CO2 has further started to accumulate in the body because of the pus which has deposited in the alveoli. The ventilation is completely blown off. There's pus now in the alveoli, right? Pneumonia is a pus in the alveoli. Whenever there's a pus in the alveoli, the ventilation of that lung is completely blown off. CO2 exchange is completely blown off. Oxygenation is completely blown off. CO2 is now stagnating because already the patient is hypoventilating. Since the patient is hypoventilating, CO2 already stagnating. With the pneumonia, there's more PaCO2 accumulation. This is an acute on chronic exacerbation. Can I say this? Everyone's clear? Everyone's clear with this? Is everything clear? So we have discussed 8 examples. We have discussed 8 examples. The one thing, is everyone clear? Can I just get a thumbs up from everyone, or a heart from everyone? A thumbs up or a heart? Come on. Can I get a thumbs up or a heart from you all? Thank you. Thank you so much. Is there anyone who is in doubt? Is there anyone who is in doubt with the 8 examples that we have talked of? Thank you. I can get a lot of thumbs up and a lot of hearts. Thank you. Thank you so much. Thank you. Is there anyone who has not understood any of these 8 examples? Any of these 8 examples, if you have not understood, please let me know. I'll be putting in an effort again. Anyone who has not understood? Thank you. Thank you. Okay. So I presume that these 8 examples are absolutely clear with you. I presume these 8 examples are absolutely clear with you. Okay. Then we have done quite a lot. Now, finally, let's move on to what is our next step when we are dealing with a metabolic problem. Okay. Respiratory problems. Okay. So for this set of problems, that is example 6, 7, and 8, we will be talking about this in respiratory failure, which is our अगला कुछ स्लाइड्स के बाद आता है respiratory failure. Right now we will be focusing on example 1, 2, 3, 4, 5, which mainly are metabolic disorders in the primary setting. Whenever there is a metabolic disorder in the primary setting, we first check the Winter's formula. In Winter's formula, if it is metabolic acidosis, we check the expected PaCO2 as 1.5 into serum bicarb plus 8 plus minus 2, correct? If it is a metabolic alkalosis, then in Winter's formula, expected PaCO2 is 0.7 into bicarb plus 20 plus minus 5. इतना correct है? इधर एक तो जल दिया मगर. इतना correct है? Everyone's clear with this? I'm just revising, nothing more. कुछ नया नहीं बता रहा हूँ. कुछ नया नहीं बता रहा हूँ दोस्त. Yes, correct. Yes, Dr. Karthik, very good. Yes, तो अभी तक हमने रिवाइज किया है, ठीक है. अब we are now focusing on what is our next step when it comes to a metabolic disorder. So first is metabolic, ठीक है. Winter's formula, ठीक है. Next step is anion gap. Now we'll move to anion gap. What is anion gap? देखो ध्यान से सुनो. In our body, we are having a certain fraction of cations which are positively charged ions. We are having a certain fraction of anions which are negatively charged ions. Now, the difference between them is what we call as the anion gap. But why is the word gap there? Cation minus anion agar hota और दोनों अगर equal proportions में होता, then the difference would have been 0. Say 8 cations, 8 anions. Difference कितना होता है? 8 minus 8, 0. But why are we saying that there's a gap? The gap is because of the fact that there are some unmeasured cations and unmeasured anions in the pool as well. Body में, blood में, there are so many anions and cations which we are not able to measure. We are only measuring the most common fraction of cations and anions. So whenever we talk of anion gap, what we are definitely meaning is sodium minus chloride and bicarbonate, which means we are considering sodium as the predominant cation. Please do not ask me why we are not using potassium, because that will take me another 2-3 hours to explain why not potassium. Please, I will take this up doubt somewhere else, sometime else, why we are not calculating potassium. But the formula for anion gap is sodium, which is the predominant cation, minus bicarb plus chloride, which are the predominant anions. Is this clear with all of you? So sodium minus chloride plus bicarb is what we call as the anion gap. Normally, the anion gap is somewhere between 10 to 12. Usually, that is the value of anion gap, somewhere between 10 to 12. So let us take it as 12 only. Agar anion gap is more than 12, we call it a high anion gap metabolic acidosis. If the anion gap is less than 12, we call it a normal anion gap metabolic acidosis. Is this clear? मैं वापस से बोल रहा हूं. I am repeating this once more. Just give me a while. I am repeating this point again. See, my friends, what I am trying to say is, पहले हम Rome criteria के हिसाब से we'll see whether it's a metabolic or a respiratory disorder. If it's a metabolic disorder, we'll find whether it's metabolic acidosis or alkalosis. Once we have found whether it's metabolic acidosis or alkalosis, we will do the Winter's formula. Now, if it is a metabolic acidosis, I'm repeating, if it is a metabolic acidosis, after checking Winter's formula, the next step is to check for anion gap. I'm repeating, if it is a metabolic acidosis, after checking Winter's formula, the next step is to check for anion gap. Anion gap is simply the measure of sodium minus bicarb plus chloride. If this value is 10 to 12, then it's normal. If it is less than 12, it is normal anion gap metabolic acidosis. If it is more than 12, we call it high anion gap metabolic acidosis. Hagma, nagma. Is this clear to everyone? Is this clear to everyone? Is the concept of high anion gap, low anion gap clear to everyone? First, check whether it's metabolic or respiratory, then check whether it's acidosis, alkalosis. If it's metabolic acidosis, do Winter's formula, check the expected PaCO2, then do anion gap. If anion gap is more than 12, it is hagma. If it's less than 12, it's nagma. Is this clear to everyone? Itna clear hai? My eyes are on the chat box. Keep on pulling your messages. Keep on pulling your messages. Is this clear? Any doubt? Abhi tak koi doubt hai? Kisi ko bhi koi doubt hai? Can someone write down the steps for me in the chat box 1, 2, 3, 4 karke? So the first, number 1 is check whether it's respiratory or metabolic based on Rome. So someone write this down for me so that everyone in this chat box is able to see it. So first thing is do Rome, check whether it is metabolic or respiratory. Second, if it is metabolic acidosis or alkalosis, go for Winter's formula. If it is metabolic acidosis, after you check for Winter's formula, do anion gap. If the anion gap is more than 12, it is hagma. If it is less than 12, it is nagma. Is this clear to everyone? Correct. Good. So, are we on the same page? Are we on the same page now? So, once we have calculated anion gap and we are now finding that the anion gap is more than 12. Now, what does it mean? Now, this is from where I will be testing your intellect. What does it mean? is the fraction of measured cations anions more, or there is some other extra unmeasured anion in the system? Suppose the anion gap is more than 12. मानो 10 से 12 होना चाहिए, anion gap is 30, 25. What does it mean? What does it mean? It means there are some unmeasured anions. It means there are some unmeasured anions in the system which we could not calculate, because in our calculation for anion gap, we only take anions as chloride and bicarb. The only cation we take is sodium. So sodium minus bicarb plus chloride, that is basically our formula for anion gap. If we are getting an anion gap that is high, it clearly means system में कुछ और भी unmeasured anions है which we were not able to measure. And what are these? These unmeasured anions are given popularly by the mnemonic called Goldmark. Again, ये मेरा mnemonic नहीं है. It's an age-old mnemonic, Goldmark. For G, it is glycols or the ethylene glycols, propylene glycols. We know ethylene glycol is used as an antifreeze agent. ठीक है? O for oxoproline. Oxoproline is a metabolite of paracetamol poisoning. L for L-lactate, D for D-lactate. L-lactate is the most common lactate that we find in severe sepsis or lactic acidosis. D-lactate is a special type of lactate that we find only in one condition, that is short bowel syndrome. M for methanol. Methanol has been again associated in the Hooch tragedy. I think everyone knows of the Hooch tragedy. That's methanol. A for aspirin or salicylates. R for renal failure or uremia. And finally, K for ketoacidosis. When we talk of ketoacidosis, there are usually 3 types of ketoacidosis that I'm mentioning. One is a diabetic ketoacidosis. Number 2 is an alcohol-induced ketoacidosis. And number 3, something that we find very rarely these days, that is starvation ketoacidosis. So in all of these scenarios, see, lactate is an lactate. बताओ मुझे, lactate is a cation or an anion? चलो, lactate is a cation or an anion? All chemistry is coming back. Lactate is a cation or an anion? It's an anion. So once anion, high anion gap metabolic acidosis में अगर D-lactate, L-lactate आ रहा है, what does it mean? कि हमने lactate measure किया ही नहीं था. If we had added lactate to the formula of anion gap, what would the anion gap have become? It would have become 0. Agreed? मतलब मानो in a patient of severe lactic acidosis, if my anion gap का formula was sodium minus bicarb plus chloride plus lactate, don't you think that the value of anion gap would have come 0? Who is writing lactate as a cation? Oh my God, no. Dr. Karthik, lactate, how is lactate a cation, darling? Lactic acidosis में H plus is the cation, lactate is the anion. Acetic acid में CH3COO minus plus H plus पे dissociate होता है ना भाई. तो Dr. Karthik, acetic acid, CH3COOH, that is acetic acid, right? It dissociates into CH3COO minus and H plus. H plus is the cation, CH3COO minus is acetate, which is the anion. ठीक है बेटा, कोई बात नहीं, कोई बात नहीं. I'm glad you're able to speak out your errors. Perfect, no issues. This is not a place for anyone to get shamed. We all learn together. Okay, now tell me this. Whenever, okay, lactic acid, yeah, okay, fine. So lactate is an anion, right? So अगर lactic acidosis है and that is giving me a hagma, does it not mean कि हमने lactate measure नहीं किया था system में? Measure किए होते तो the anion gap would have been normal or 0. कोई gap ही नहीं होता ना. So the word anion gap, the word gap in the anion gap means it is the gap that has been left by the unmeasured fraction of anions. हालांकि cations anions दोनों, but because we have almost measured all the cations in the body, but we have not measured the anions appropriately, because there are so many toxic metabolites that are produced in the body at every single amount of time. So many each of those anabolic processes or the catabolic processes releases a lot of anions. So the anionic pool in the body is always very, very, very large. Out of the large anionic pool, we are only able to measure chloride and bicarb. The moment we are able to measure lactate, so it would have been a normal anion gap. But because we were not able to measure lactate, and the high levels of lactate is what contributed to hagma. What does it mean? That it is the unmeasured fraction of the lactate which is contributing to the anion gap. Can I say that? Can I say that? Everyone is in sync with me. So all of this, glycols, oxoproline, salicylate, lactate, all of these are basically unmeasured anions. They contribute to the fraction. They contribute to the fraction or the larger fraction of the unmeasured anions, thereby increasing the anion gap. Can I say that? Can I say that? Is this clear? Everyone's clear with this? Sahi hai? Everyone's clear with this? Everyone's clear with this? Okay, good. Now, let's move to normal anion gap metabolic acidosis. Now, once we have seen anion gap more than 12 makes it Hagma. We have the causes of anion gap. Once we have seen anion gap and it is normal, that is less than 12, then it is a normal anion gap metabolic acidosis. Now, can you see the formula? Sodium minus chloride plus bicarb. If in this formula, if the anion gap has to be low or normal, what does it mean? Either chloride can be excessive, matlab, in spite of having a normal anion gap, the patient is still having acidosis. ये कैसे हो सकता है? In spite of developing a normal anion gap, the patient is having acidosis. दो ही कंडीशन है, या तो उसके बॉडी में बाइकार्ब नहीं है, सो बाइकार्ब इज बीइंग लॉस्ट, नहीं तो उसके बॉडी में क्लोराइड बहुत ज्यादा है, क्लोराइड इज बीइंग गेन्ड. कैन आई से दैट? नहीं तो द थर्ड ऑप्शन which again comes to us is there is a H plus gain which is happening from outside. Three reasons why which despite a normal anion gap the patient will still have an acidotic pH. या तो उसके बॉडी में एसिड बहुत ज्यादा प्रोड्यूस हो रहा है, सो H plus gain, नहीं तो बाइकार्ब बहुत ज्यादा लॉस हो रहा है यूरिन में, बाइकार्ब लॉस, नहीं तो क्लोराइड बहुत ज्यादा आ रहा है उसके बॉडी में, दैट इज अ क्लोराइड एक्सेस. Anyone who is having a doubt as to the three mechanisms of acidosis in the setting of a normal anion gap? Anyone with any doubt with the three mechanisms of acidosis in a normal anion gap? यानी कि कोई unmeasured anion नहीं है, but still the patient is having an acidotic pH. या तो पेशेंट के बॉडी में एसिड बहुत ज्यादा बन रहा है, H plus excess, नहीं तो पेशेंट के बॉडी में बाइकार्ब बहुत ज्यादा लूज हो रहा है, बाइकार्ब डिप्लीशन, नहीं तो तीसरा चीज पेशेंट के बॉडी में क्लोराइड बहुत मात्रा में है, क्लोराइड एक्सेस. इज दिस क्लियर? Anyone who is doubtful, anyone who can explain me why chloride excess can lead to acidosis? Chalo, I'll give them a chocolate. Anyone who can explain me why chloride excess can lead to acidosis? Anyone explaining me why chloride excess can lead to acidosis? Why is the chat box shant? Why? No one is able to tell me. No one, really? Come on, you're better than this. Come on. Why can chloride excess lead to a normal anion gap metabolic acidosis? Anyone? Nah, not renal failure. No. Will bring in H plus to compensate. थोड़ा बहुत सही है, not really. Oh my god. Okay, okay, somebody is written excess chloride, hyperchloremic metabolic acidosis by displacing serum bicarbonate to maintain electroneutrality. Very good. Who's this person? Dr. Wait, I need to read your name. Dr. Kranti Naidu, Dr. from Hyderabad. Hi, Dr. Kranti Naidu. Fantastic. Yes. So Dr. Kranti Naidu from Hyderabad has said the correct answer. Absolutely. Chloride will always compete with bicarb. Chloride is a negative anion. It's a negative charged ion. Bicarb is a negatively charged anion. जब chloride body में excess होगा, it will fight with bicarb and kick it away. So when bicarb is kicked away, now chloride, see, when bicarb was there, it was binding with H plus and forming H2CO3, right? When chloride is there, it will bind with bicarb, with hydrogen and will lead to the formation of HCl. HCl is a stronger acid. This is the first reason why. Number two, because bicarb is being lost when chloride is in excess, bicarb is being pushed away. Lower bicarb levels also contribute to the metabolic acidosis of the patient. Is this clear? Come on, I'm so proud of you, Dr. Kranti. So proud. So I'm repeating this concept. So there are three mechanisms. See, when I talked of nagma, it clearly means कि अब सिस्टम में सिर्फ कैटायन बोले तो सोडियम है, एनायन बोले तो क्लोराइड और बाइकार भी है, और कुछ नहीं है. There is nothing, no unmeasured fraction. अब जो भी है problem has to be with chloride and bicarb. So if the patient is acidotic despite a normal anion gap, it means either bicarb is low or acid is more in the body, means H plus कहीं से gain हो रहा है, नहीं तो chloride is in excess. Now why chloride excess causes acidosis is because chloride is an anion. It will selectively compete and aggressively compete with bicarb to maintain electroneutrality, because it will say कि देखो जैसे एक जंगल पे दो शेर नहीं हो सकते, वैसे ही एक एनवायरनमेंट में दो कैटायन नहीं हो सकते, दो एनायन नहीं हो सकते, या तो तुम रहोगे नहीं तो मैं रहूंगा. So if chloride is more, it will kick off bicarb. When bicarb is kicked off, it contributes to acidosis. Number one. Number two, if bicarb was there, it would have bound to H plus to form H2CO3, which would lead to an acid, but not as strong an acid as HCl is. HCl is a stronger acid than bicarbonic acid. Is this clear? Is this clear? Kranti, have I explained this well? Dr. Kranti, is this what you wanted to say? Have I done this well? Thank you. Thank you. Everyone's clear? Everyone's clear? Good enough. Thank you. Thank you so much. Now, okay. So, my friends, what I was saying is, whenever I am having a nagma, I can have either a situation of chloride excess or depletion of bicarb or gain of H plus. अब मुझे एक बात बताओ, tell me one condition where there is chloride excess. One condition in the body जब chloride is in excess. Where is chloride in excess? कब होता है हमारी बॉडी में क्लोराइड एक्सेस? ज्यादा क्लोराइड कब आता है? No, who is saying cystic fibrosis, man? No. Chloride is not, man. Cystic fibrosis has more amount of chloride in the sweat, dear. Serum chloride levels कहाँ से increase होता है बाबू? No, not cystic fibrosis, my dear. I'm asking of a real life scenario. It's such a simple scenario. यार, whenever you are given sodium chloride, जब हम excess saline लेते हैं ना, that is when there is an excess infusion of sodium chloride in the body, it leads to hyperchloremia. Is this clear? Everyone agrees? इसीलिए कोई vomiting में आता है तो उसे ऐसे ही मतलब fluid मत देते जाओ. See how much sodium you have to correct. Is this clear? Everyone's clear with what I'm saying? Any patient comes to you in the ER with vomiting, do you just give them 10 bottles of sodium chloride? No, na? Because if you give 10 bottles of sodium chloride, you know what is going to happen. Sodium का तो कुछ नहीं होगा. Chloride will keep on excessively increasing. It will lead to metabolic acidosis. Is this clear? So the one condition of a nagma where there is chloride excess is sodium chloride. In fact, आज के दिन में it's the most common indication. It's an iatrogenic condition, but it's a very important condition. The other conditions like ureteric diversion and all of that, I am not even going to consider. Okay? It's a very old theoretical concept that ureteric diversion, or what we used to call, wherein the ureter would be connected to the sigmoid colon in certain surgeries. तो क्या होता था? The sigmoid colon would actually be absorbing a lot of chloride. एक बात बताओ, urine has more chloride या your potty has more chloride? Your shit has more chloride or your pee has more chloride? Anyone? Shit has more chloride या pee has more chloride? Very good. Urine has more chloride. ठीक है? Yeah, very good. So if you connect the ureter to the sigmoid colon, if you connect the ureter to the sigmoid colon in a surgery, what is supposed to happen? The sigmoid colon will rapidly try taking up chloride. Is this clear? And hence it will again be a case of hyperchloremic metabolic acidosis. Am I clear? Hyperchloremic metabolic acidosis. Is this clear? But आज के दिनों में you rarely do these surgeries. So the main cause of chloride excess leading to nagma is nothing but sodium chloride infusion in a higher amount. Clear? Now, finally, this one part is done. Number two, pure depletion. Pure depletion में क्या हो सकता है? या तो प्योर डिप्लीशन ऑफ बाइकार्ब हो रहा है, नहीं तो इतना ज्यादा H plus is being produced in the body that bicarb is relatively less than the amount of acid already in the body. Let us consider what are the causes where there is bicarb loss from the body. Can you tell me what are the conditions where there is bicarbonate being lost from the body? Which is the digestive juice or which is the digestive secretion which is the highest number of bicarb? Highest bicarb कौन से secretion पे है? Which digestive juice has the highest bicarb secretion? Pancreatic. Very good. So in the case of a pancreatitis, chronic pancreatitis or any pancreatic insufficiency, can we not say that there will be bicarb loss in the from the body? Can I not say this? Very good. Number one. Number two, vomiting causes acidosis या alkalosis? Quickly, vomiting causes acidosis या alkalosis? Jaldi jaldi. Vomiting causes, very good. Vomiting causes, okay, I've got one answer, alkalosis. Everyone is in sync with it. Vomiting causes alkalosis या acidosis? Jaldi. Oh my God. Okay, somebody said acidosis. Okay, I'll correct you. Okay, vomiting always causes alkalosis. Vomiting always causes alkalosis. See, when you are vomiting, my dear, you are vomiting out the acid. Acid is HCl, right? So H plus निकल रहा है तुम्हारे body से, Cl minus भी निकल रहा है. I just now told you, H plus body से निकलेगा तो you will have alkalosis ना. H plus is lost by the body. जब आप vomit कर रहे हो, you are throwing out the acid. पेट के acid बाहर निकल रहा है ना, तो H plus बाहर निकल रहा है, which means you are becoming more alkalotic. So vomiting leads to alkalosis, whereas diarrhea leads to acidosis. Is this clear? Vomiting leads to alkalosis, whereas diarrhea leads to acidosis. Am I clear? Can I therefore say that the HCO3 minus loss can happen either through diarrhea or it can be a pancreatic loss due to chronic pancreatic insufficiency or whatever it is? Am I clear? Am I clear? Or there can be another condition which Dr. Saurabh has rightly said, renal tubular acidosis. Okay, Saurabh, what type of renal tubular acidosis will lead to a depletion of bicarb? What type of a renal tubular acidosis will lead to a depletion of bicarb? Saurabh, since you have mentioned RTA. Type 1 RTA? No. No. Type 1 RTA? No. Type 1 RTA will not cause bicarb loss. It will cause H plus gain. Type 1 RTA will cause H plus gain. So proximal or the type 2, exactly. So doctor, yeah, very good. Everyone has been saying 2 in larger numbers. Yes. So it is type 2 or the proximal segment of the nephron. See, I can understand you're a bit confused between the physiology in proximal and distal nephron. एक बार जल्दी से physio recap कर लेते. एक बार जल्दी से clear head. Remember this. I'm telling you the exact physio of proximal and distal nephron in 3 minutes. ध्यान से सुनो. Proximal part of the tubule is supposed to reabsorb bicarbonate. Clear? Is this clear? हाँ या ना में बताओ जल्दी, quickly. Thumbs up दे दो, उतना काफी है. Proximal part of the nephron reabsorbs bicarb. Clear है? Clear? Clear? I want active participation from everyone. Proximal part of the nephron reabsorbs bicarb. So if the proximal nephron is not working well, will the bicarb be lost in urine? Yes or no? Proximal part reabsorbs bicarb. अब proximal part काम नहीं कर रहा है, bicarb urine से निकलेगा कि नहीं निकलेगा? Clear? Correct. So can I therefore say proximal or a type 2 RTA will lead to bicarb loss? Can I say that? Can I say that? Very good. Very good. What does the distal nephron do? The distal nephron is usually involved in acidification of the urine. अब वो कैसे acidify करता है? ध्यान से सुनो, please ध्यान से सुनो, please ध्यान से सुनो. See, ammonia is something that is produced in the proximal nephron. Ammonia, NH3, ammonia is produced in the proximal nephron. It is carried by the circulation to the distal nephron. अब proximal nephron से ammonia goes to the distal nephron. In the distal nephron, we have certain cells called I cells and the P cells. These are all cells of the cortical collecting duct and the distal convoluted tubule. यानी कि distal part of the nephron is usually involved in acidification. What do I mean by acidification? It will throw acid. It will excrete acid. Along with acid, what it will do is this ammonia which was coming from the proximal segment, this will bind with that H plus, and ammonia and H plus will form something which is a non-toxic compound called ammonium NH4 plus. इतना clear है? वापस से बोलता हूँ. proximal segment bicarb को reabsorb करेगा, proximal काम नहीं कर रहा है, bicarb is lost in urine, that is type 2 RTA. Clear? Proximal segment produces NH3, ammonia. Ammonia is carried to the distal segment where H plus is being excreted or thrown out into the lumen. This H plus combines with the ammonia to form NH4 plus, ammonium, which is a non-toxic compound. Clear or not? Now, ammonium cannot get out through urine on its own. It will need its brother, that is chloride. So it combines with chloride to form ammonium chloride, NH4Cl. Is this clear or not? Is this clear or not? Good. So can I say urinary chloride levels are a very good marker for the functioning of distal nephron? Can I say this statement? Urinary chloride levels, ध्यान से सुनो मेरी बात. Urinary chloride levels are a very good marker for the functioning of distal nephron. Can I say this? Yes or no? Very good. Can I therefore say agar urinary chloride high hai, which means the distal nephron is working fabulously well. Ammonium ions are being generated and H plus acidification of urine is also happening. Can I say that? Can I say that? Very good. Thank you. Thank you so much. Every one of you. Thank you. Anyone who's not understood what I've said till now? कोई है जो नहीं समझा है मैंने क्या बोला है? Anyone who has not understood it? So we were talking of nagma. Whenever we talked of nagma, we talked of three conditions: chloride excess, that is excess infusion of sodium chloride. Number two, pure depletion of bicarb, that is occurring due to a renal cause, type 2 RTA, because renal में bicarb was supposed to be reabsorbed by the proximal segment. वो नहीं हो रहा है, type 2 RTA. Number three, pancreatic losses or GI losses or diarrhea, because vomiting leads to alkalosis, diarrhea will lead to acidosis. So that is one part. The other part of depletion of HCO3 minus leading to acidosis can also be because the system gained some excess H plus ions. H plus कहीं से बाहर से system में आ रहा है, which means there is an excessive acidification of the body going on. वो कब होगा? The distal nephron is what was supposed to take part in acidification of urine. It was supposed to throw H plus ions into the lumen. But if the distal nephron is not working, what is the type of disorder? That is type 1 RTA. When the distal nephron is not working, when the Na plus K plus ATPase, Na plus H plus ATPase channels are not working, H plus ions are not thrown into the lumen, which means they are accumulating in the blood, leading to an increased H plus in the system. That is type 1 RTA. Am I clear or not? Am I clear? I hope you're not under your blankets and feeling sleepy. Come on. Show me your energy in the chat box. Come on, all of you. Anyone who's not understanding what I'm saying, because see, what I'm trying to tell you is basic physiology. I am trying to tell you the acidification of urine, यानी कि urine में H plus ions छोड़ने का काम किसका है? distal nephron का. अब distal nephron काम नहीं कर रहा है, तो urine acidify नहीं हो रहा है, उल्टा क्या हो रहा है? H plus blood में बढ़ रहा है. Acidification of blood is happening. That is type 1 RTA. Clear or not? नहीं तो what is another hormone that was required in order to throw H plus and K plus into the lumen? That was aldosterone. So if aldosterone is not working, I mean either there is an aldosterone deficiency or the cells of the distal nephron are insensitive or they are absolutely irresponsive to aldosterone or aldosterone resistance. Then also acidification of the urine will not happen. H plus ions will accumulate in the blood. That is type 4 RTA. Is this clear? Everyone is clear with this? मैं वापस रिपीट करता हूं ये पूरा सिनेरियो ये था दोस्त कि HCO3 माइनस लॉस हो सकता है या तो पैंक्रियाटिक सिक्रीशन से, नहीं तो डायरिया से, नहीं तो टाइप 1 RTA से. H प्लस गेन हो सकता है कैसे? या तो डिस्टल नेफ्रॉन काम ही नहीं कर रहा है. काम इसलिए नहीं कर रहा है तो इसलिए एसिडिफिकेशन ऑफ यूरिन नहीं हो रहा है, H प्लस इज एक्यूमुलेटिंग इन ब्लड, टाइप 1 RTA. नहीं तो aldosterone which was supposed to make the distal nephrons acidify is not there. Aldosterone is lost either in cases of Addison's disease or there's a resistance to aldosterone which leads to type 4 RTA. Is this clear? So type 1 RTA leads to nagma, type 2 and type 4 RTA also leads to nagma, but the but the mechanism of the RTA, mechanism of the nagma is different. Am I clear? Am I clear? So proximal or type 2 RTA is going to lead to nagma because of HCO3 minus loss. distal type 1 or type 4 RTA is going to lead to nagma because of excess acidification of the blood instead of urine. Is this clear? Clear. Good. So, whenever we have a nagma, these are the conditions that we predominantly talk of. So, these are the conditions that we predominantly talk of. So, now I'll be taking you back to this slide. Finally, can I say this? That whenever there is a nagma and I really need to find whether the cause is a bicarbonate loss, matlab proximal nephron is not working, or whether the cause is a H plus gain, yani ki distal nephron is not working. Can you tell me one marker which will tell me how to differentiate between the causes of nagma, HCO3 minus loss या कि H plus gain? कौन help करेगा differentiate करने में? Any one marker that will be helping me to differentiate. If you have heard me speak till now, you'll be able to answer this. I'm repeating, HCO3 minus loss from the kidney is seen in type 2 RTA where the proximal nephron is not working. H plus gain in the system is leading to a condition where type 4 or type 1 RTA ho raha hai because the distal nephron is not working. What is one marker that will be enabling me to see ki is the nagma due to a proximal nephron defect or a distal nephron defect? It is actually urinary chloride. Exactly. It is not just chloride. It is urinary chloride, not serum chloride. It's urinary chloride because I clearly said urinary chloride is the best functional marker for distal nephron functioning. Because urinary chloride jitna बढ़ेगा, it means ammonium chloride utna produce हो रहा है, which means acidification utna ज़्यादा हो रहा है. So in cases of a bicarbonate loss, which is due to a proximal nephron defect, urinary anion gap. What is urinary anion gap? It's nothing. It is urine sodium. Just a minute. What is urinary anion gap? It is urine sodium plus potassium minus chloride. It is urine sodium plus potassium minus chloride, which means if the urinary anion gap is negative, yani ki urine chloride is absolutely fine because the proximal nephron is the distal nephron is perfectly working. In cases of a type 2 RTA, the proximal nephron has the problem, which means distal nephron is perfectly working. Urine chloride is going to be very, very high. So the urinary anion gap is going to be negative. Whereas in case of a type 1 or a type 4 RTA, where the distal nephron is the defect, urinary chloride will be low, which makes the urine anion gap positive. Is everyone clear with this? Is everyone clear with this? All of this is clear? All of you clear about this? Clear? Good enough? Anyone having any doubts? Any doubts? Any doubts? I'm repeating, any doubts? Any doubts? So, till now, let us revise whatever we studied. Rome. After Rome, if it's a metabolic problem, check for Winters. After Winters, check for anion gap. Anion gap is low, anion gap is high, Hagma. It means unmeasured anions are more. You have the list of Hagma, that is gold mark. If anion gap is normal, Nagma. Nagma किस वजह से हो सकता है? या तो क्लोराइड बढ़ा है, which is sodium chloride infusion excessively done. नहीं तो HCO3 is less. HCO3 is less either because it is lost through the body, type 2 RTA, proximal nephron not working, or diarrhea or pancreatic losses. नहीं तो H plus बहुत ज़्यादा body में बढ़ रहा है. It is not being thrown in the urine. Type 1 RTA or type 4 RTA. Either due to type 1 RTA where pumps are not working for acidification, or type 4 RTA where there is aldosterone deficiency or aldosterone resistance. इतना clear है? How to differentiate both of them? The urinary chloride marker is a very important marker for checking the distal nephron function. If distal nephron is not functioning well, it clearly means urinary chloride will be low. So urine anion gap, which is nothing but sodium plus potassium minus chloride, this will be positive. If the urine chloride is high, as in cases of proximal nephron problems, because the distal nephron is perfectly working, urine chloride levels will be very high. So the urine anion gap will be negative. Is this clear to everyone? This is exactly the summary of what I have been saying. This is exactly the summary of what I have been saying since the very long time. Is this clear? ठीक है, बन गया, good. Okay. Now the little box that is there below, can you all see? Can you all see that little box which is telling of low or a negative anion gap? What is a negative anion gap? Negative anion gap. What is an anion gap? I said anion gap means cations minus anions. Negative है, इसका मतलब क्या है? Maybe the anions are so high, or the cations are so low. Correct? Or there is an increased in unmeasured cations. कुछ ऐसे cations है जो हमने measure ही नहीं किया है. There are some cations which we couldn't measure only. That's why the anion gap is negative or low. What are the unmeasured cations that we get usually in practice? Calcium, magnesium. So in a patient of hypercalcemia, can you name me one hematological disorder where there is hypercalcemia? One hematological disorder where the calcium levels are off the roof. It is multiple myeloma. In multiple myeloma, we have the slim and crab criteria, right? Multiple myeloma has hypercalcemia, so high calcium levels. Again, it will lead to a negative or a low anion gap. Okay. Some conditions like pseudohyponatremia. What do I mean by pseudohyponatremia? See, usually this is a very big topic, but I'll be trying to explain it to you in a very short while. Whenever we measure sodium fraction in the blood, we have to keep an account of two things. Number one, the protein content in the blood, that is albumin. Lipids, yes, exactly. I'm getting so good answers. Cholesterol and lipids. Yes. So anytime there's an increased lipid fraction, यानी कि LDL बढ़ा हुआ है, नहीं तो triglycerides बढ़ा हुआ है, or there is a hypoalbuminemia, यानी कि albumin is low in the blood. All of these will lead to factitious or pseudohyponatremia. In all of these conditions, अगर sodium कम है, do you realize sodium minus bicarb plus chloride? अगर sodium कम है, तो it will be a negative anion gap. ठीक है? So mainly for the clinical point of view, I'll tell you to think of two conditions. One is multiple myeloma. The other one is going to be hypoalbuminemia and hypertriglyceridemia or hyperlipidemia. These are the three conditions that I'll tell you to think whenever you are encountering a case of negative anion gap. Okay. Finally, what is HCO3 minus deficit? So whenever a patient is coming to you with, this entire slide is of metabolic acidosis, right? चाहे वो नगमा हो हगमा हो, the treatment of it is to replete the bicarb levels, especially in the case of nagma. The repletion of bicarb becomes so important. In a case of nagma, the repletion of bicarb becomes so important. Now, what exactly happens in nagma? If you have to replete the bicarb, how much will you replete the bicarb is calculated by the bicarb deficit formula. It is 0.4 into body weight into 24 minus serum bicarb. That is exactly the value. Why 24? Because the standard value of range of bicarb is 22 to 28. तो हम लोग 24 average पकड़ते हैं. So 0.4 into body weight into 24 minus serum bicarb. That is the amount of milliequivalence that you will need to correct bicarb for. ठीक है? At a time, your target is to never give more than 50%, since it can result in paradoxical acidosis. ठीक है? It can result in paradoxical acidosis. क्यों? This HCO3 will be combining with H plus in the distal nephron to form H2CO3, and this H2CO3 will dissociate into H2O plus CO2. This CO2 fraction will contribute to the acidotic state of the pH. ठीक है? एक ही बात याद रखना है. In short, the bicarb deficit needs to be repleted, especially in cases of nagma. And whenever you are repleting the bicarb, the formula is 0.4 into body weight into 24 minus serum bicarb. Is this clear to everyone? Is this clear to everyone? Is this clear to everyone? सही है? Everyone's happy? Everyone's clear? Perfect. Okay. Okay. Now, finally, so this is one diagram which where I've tried to show you about the renal handling of these solutes, which I already talked about, the physio component. Finally, the last step when we are seeing a metabolic disorder, metabolic acidosis, is to find out the delta ratio. Now, what is the delta ratio? So you can clearly see this is one of the best slides that I've actually found. So delta ratio is delta anion gap. What is delta anion gap? So it's anion gap minus, it is the 12 minus anion gap divided by 24 minus serum bicarb levels. What is delta anion gap? It clearly means the amount of anion gap that is present in the patient minus 12. So anion gap minus 12. 12 is the standard anion gap value that we take, divided by 24 minus serum bicarbonate. That is 24 is the standard bicarb levels that we check. So delta ratio is basically the change in anion gap relative to the change in bicarb levels. I repeat, it is the change in anion gap relative to the change in bicarb levels. Can you quickly write down the formula for me? Can you quickly write down the formula for me in your pages or copies or wherever you are? Write down, it is anion gap minus 12 divided by 24 minus bicarb. Anion gap minus 12 divided by 24 minus bicarb. Is this clear? Now, I'll explain you what is the importance of the anion gap. Yes, it is anion gap minus 12 divided by 24 minus bicarb. Correct. Okay. Now, I'll explain you what is the importance of anion gap, especially in dealing with hugma. So, anion gap is a step that we mainly do in cases of dealing with hugma. So, what are we doing in anion gap? Suppose I'm talking of an acid which is leading to hugma, that is lactic acidosis. Agreed, everyone? Lactic acidosis, which we find in severe sepsis, will lead to hugma. I hope nobody is going to say nagma for this. Lactic acidosis doesn't cause nagma, I hope, because it's an unmeasured fraction of the anion. Everyone's clear? Lactic acidosis, hugma, right? Everyone clear? Lactic acidosis, hugma. Good. So, when I talk of lactic acidosis, what does it dissociate into? It dissociates into 1H plus and 1 lactate ion. Is that correct? When I talk of lactic acidosis, it dissociates into 1 H plus ion, 1 lactate ion. Correct? Lactate is the anion, H plus is the cation. Clear? Clear? Now, do you agree that the one molecule of lactate that was produced was supposed to increase the anion gap by 1 unit? Agreed? 1 unit of 1 molecule of lactate or 1 mole of lactate that was produced. चलो chemistry का वो molality पे जाते हैं. Revisiting those traumatic days in case chemistry was trauma for you. So lactic acid dissociates into H plus ion, which is a cation, and a lactate, which is an anion. Now, 1 molecule of lactate is supposed to increase the anion gap by 1 unit. Agreed? And 1 unit of 1 molecule of H plus is supposed to neutralize HCO3 minus and therefore decrease the serum bicarbonate levels by 1 unit. Agreed? Agreed? कोई doubt है इस पे? If my body is compensating well, 1 molecule of lactic acidosis, 1 molecule of, I'm repeating again. Dr. Nimjam, I'm repeating again. Whenever there is lactic acidosis, suppose there is 1 molecule of lactic acid, it dissociates into 1 H plus ion and 1 lactate ion. Clear या नहीं clear? Clear है? Dr. Nimjam, is this clear? 1 molecule of H plus, 1 molecule of lactate produced from 1 molecule of lactic acid. Clear hai? Good. Now tell me one thing. 1 molecule of lactate is supposed to increase the anion gap by 1 unit. Clear hai? Good. 1 molecule of H plus is supposed to reduce the serum bicarb by 1 unit. Clear hai? Good. Good. Now, consider you have a case scenario where the anion gap has increased by 1, but the serum bicarb has reduced by 10. Any weird scenario where the anion gap has reduced by 1, but the serum bicarb has reduced by 10. What will you infer? In such a scenario, what will you infer? यानी कि anion gap has reduced by 1, but the serum bicarb has reduced by 10. Can you therefore say that something was causing more loss of bicarb from the system than the expected? Can I say that additionally kuch HCO3 minus loss ho raha tha? Correct, absolutely correct. What is the acidosis? Is it hugma or nagma that causes an associated bicarb loss? Can hugma cause an associated bicarb loss or a nagma cause an associated bicarb loss? Yes, it is nagma. Therefore, can I say that now this patient has both a hugma due to the lactic acid and a nagma due to excessive bicarb being lost from the system? So it's a mixed case of hugma with a nagma. Can I say that? Can I say that? Good. Let me also give you another example. Suppose now my bicarb levels Okay, my 10 units is the change in anion gap. How many bicarb should have been lost? 10 bicarb should have been lost, right? 10 units is the change in anion gap. Then 10 units of bicarb should have been lost. Agreed? Agreed? अगर 10 यूनिट एनायन गैप बढ़ रहा है तो 10 यूनिट बाइकार्ब लॉस होना चाहिए था सिस्टम से आइडियली. बट मानो 8 units of bicarb are being lost. Can I say that there is an additional bicarb which is being added to the system? Or can I say that excess acid is being produced in the system? Can I say that? Can I say that excess acid is being produced in the system? Can I say that excess acid is being produced in the system? Exactly. So now I'll be telling you to look at this case, which is highlighted in orange color. Can you tell me what is the diagnosis? ध्यान से देखो. ध्यान से देखो. Is the pH normal? चलो एक साथ करते हैं. Is the pH normal? Is the pH normal? Yes. Is the PaCO2 normal? Yes. Is the bicarb normal? Yes. Okay. Now, what is the anion gap coming out? Anion gap? What is the anion gap coming out? Anyone? Anion gap कितना आ रहा है? 134 minus 88 plus 23. कितना आता है? Around 23, right? 23 anion gap. More than 12 या less than 12? Is it hagma, nagma? जब 23 है मेरा anion gap, is it hagma or nagma? Hagma. Very good. Whenever there is a hagma, what is my next step to check the delta-delta ratio? What is the delta ratio? 23 minus 12, anion gap minus 12 divided by 24 minus bicarb, which is 23 minus 12 divided by 24 minus 3. कितना आता है? 11. 11. Okay. What does delta ratio of 11 mean? That, can I write 11 as 11 by 1? Can I therefore say that when the anion gap rose by 11, only 1 unit was bicarb was lost? Only 1 unit of bicarb was lost. Can I say that? Ideally, with a rise of 11 units of anion gap, 11 units of bicarb should have fallen. But now I'm seeing a system where with 11 bicarb, 11 units increase in anion gap, only 1 unit of bicarb is lost, which means somebody is adding bicarb to the system. When bicarb is added to the system, what is it? Is it metabolic acidosis or alkalosis? Is it metabolic acidosis or alkalosis? Alkalosis. What is the diagnosis of this ABG now? It is metabolic. It is, what is the diagnosis? It is a hagma with metabolic alkalosis. It is a hagma with metabolic alkalosis. Now, if you forget everything, can you just check what is the clinical feature of this patient? There is uremia, there is AKI, there is bleeding. Can you now tell me, can you explain me the features right now? Uremia will lead to hagma. Agreed? Uremia is going to lead to hagma. Okay. Once there is hagma, what will start happening in this patient? What will start happening in this patient? Once there is hagma, what will start happening in this patient? What will start happening in this patient? What is going to lead to the metabolic alkalosis? What will lead to the metabolic alkalosis? Why is the metabolic alkalosis happening? Why is the metabolic alkalosis happening? Hagma is explained. Tell me. This patient is a patient of uremia, AKI, and bleeding. See, whenever there is a patient of uremia, it means this is a patient of basically CKD or acute on chronic onset of CKD, right? So the high anion gap is explained by uremia. How is the alkalosis confirmed? Whenever there is uremia, whenever there is bleeding, do you realize that this is going to lead to hypovolemia in this patient? Agreed? Hypovolemia होगा कि नहीं होगा? जब पेशेंट को यूरेमिया होगा उसके साथ हाइपोवोलेमिया होगा कि नहीं? क्यों? यूरेमिया ऑल्सो लीड्स टू वॉमिटिंग. इज इट क्लियर? यूरेमिया ऑल्सो लीड्स टू वॉमिटिंग. Whenever you are vomiting, what are you losing? Acids. What will it lead to? Metabolic alkalosis. Agreed? Agreed? Also, whenever there is volume depletion over a long time, if it's a chronic volume depletion, RAS system starts getting activated. What does RAS do? Sodium and water reabsorption, potassium and hydrogen excretion. H plus nikal raha hai wo. Metabolic alkalosis explained. Along with it, there will be hypokalemia because K plus will be kicked out. Very good, very good. ठीक है, समझ गए? Is this clear? So the clinical scenario will actually guide you a lot about what the ABG is presenting. I'm repeating this case. This patient had absolutely, पहले हम देखेंगे ना तो लगेगा सब कुछ नॉर्मल है. Once, so can I therefore, okay fine, can I therefore make a big statement? In this patient the pH was normal, right or wrong? Can I make a big statement that the pH in this patient was normal, right or wrong? Normal tha pH, 7.4 is a normal pH, right? Therefore, can I say that a normal pH does not rule out an acid-base disorder? Can I say that? A normal pH does not rule out an acid-base disorder. Can I say that? Very good. जब मैंने ECG का क्लास लिया था बहुत महीने पहले, I said that a normal ECG does not rule out a cardiac event. Did I say that? So a normal ECG does not rule out a heart attack, an MI. A normal ABG does not rule out an acid-base disorder. You have to keep in mind the clinical scenario. The moment you did an anion gap, you found out one thing, that it's a high anion gap. Uremia explains the high anion gap metabolic acidosis, but uremia would also lead to bleeding, lead to vomiting. Whenever there is vomiting, the patient will throw out acids. So metabolic alkalosis, one. Number two, whenever there is chronic vomiting, always remember, see why I'm talking of chronic vomiting. Okay, there's one thing what I want you to know. See, diarrhea बंद करने के लिए बहुत दवाई है. You give, the drugs which do not increase the motility of the intestine, loperamide दे दो, जो भी है, ठीक है. Don't give metrogyl for diarrhea, please. But vomiting का सिर्फ एक ही medicine है, that is fluids. Why? Because when you are vomiting acutely, you are throwing out a lot of HCl, and the only thing that can reinfuse Cl minus back into your body is sodium chloride. And also in chronic vomiting, chronic episodes of vomiting, you are not just losing chloride, but you're also losing sodium. That is why fluids, sodium chloride is the best form of treatment when somebody is vomiting for a long time. Is this clear? Now, this patient of uremia was also vomiting. When this patient was vomiting, what it led to is, this led to a volume contraction, leading to a increase in the RAS activation. Whenever RAS was activated, aldosterone was activated, H plus was kicked out along with potassium, which led to further metabolic alkalosis, explaining why this diagnosis is a HAGMA with metabolic alkalosis, which means there's a high anion gap metabolic acidosis with the metabolic alkalosis also simultaneously occurring in the patient. Clear? So delta ratio should ideally be 1, right? Change in anion gap minus 12 should be almost equal to change in bicarb, 24 minus bicarb, right? 1 unit change in anion gap should be congruent to 1 unit change in bicarb. But usually in our body, it's a system. हर चीज को हम बांध नहीं सकते, तो we keep a value of 1 to 2 या फिर 0.8 to 2. If the value of anion gap is more than 2, as in this case, it means that bicarb is being added to the system. That is metabolic alkalosis. If the value of delta ratio is less than 0.8, it means bicarb is being lost from the system. That is metabolic acidosis. Is this clear? ठीक है? ठीक है? Is this clear? Yes, absolutely clear. Very good. By this, we have come to the conclusion of our metabolic disorders. And before I say that, I would want you to solve one question for me. Please solve this question. Please solve this question. Are you all able to see the question या फिर मेरा chat box बीच में आ रहा है? Can you just confirm it to me? Are you able to see the question या मेरा chat box आ रहा है बीच में? Question दिख रहा है? Question दिख रहा है? सबको दिख रहा है question? Values दिख रहा है? वैल्यूज दिख रहा है सबको? कम ऑन. 30-year-old female admitted to the ICU following a traumatic brain injury. ABG is normal on arrival. Condition has deteriorated since admission. Now she has circulatory failure requiring NORAD support. ABG is given. First, tell me what is the primary component in the ABG? What is the primary component? Jaldi, jaldi, jaldi. What is the primary component? Primary component क्या है? Metabolic acidosis. Yes, good. Very good. Dr. Krupa. Very good. Metabolic acidosis. Next step क्या है? Once we have found out metabolic acidosis, what's our next step? Winter's formula. Winter's formula से क्या पता चलेगा? PaCO2 expected. निकालो. कितना है PaCO2 expected? कितना है? कितना expected PaCO2 है? Next one देना. दागे ऐसे हमारे. Yellow डॉक्टर मुझे. What is the expected PaCO2? Yellow plastic. No, borrow. No. What is the expected PaCO2? Yes, it is 23 to 27. Very good. What is the PaCO2 here? कितना दिया हुआ है PaCO2? कितना PaCO2 दिया हुआ है? Is it higher than the expected or lower than the expected? Higher than expected या lower than expected? अरे क्या बोल रहे हो यार? क्या बोल रहे हो? सही कैलकुलेट करके फिर गलत कैसे बोल रहे हो? PaCO2 is 35 here ना? आपका एक्सपेक्टेड 23 to 27 है. इट इज हायर देन एक्सपेक्टेड. वेरी गुड. तो अगर CO2 हाई है तो क्या कंपोनेंट ऐड होता है यहाँ पे? अलोंग विथ मेटाबॉलिक एसिडोसिस, व्हाट इज द अदर कंपोनेंट इफ एक्सपेक्टेड PaCO2 जितना होना है उससे ज्यादा है CO2 यहाँ पे? Yes, so what is the final diagnosis of this? Metabolic acidosis with your expected PaCO2 was 23 to 27. Your PaCO2 in this patient is 35. So what is the diagnosis? जितना expected था उससे ज्यादा CO2 है. What is it? क्या यार? What is wrong? We have been doing this since such a long time. हाँ, mixed है. क्या है? Very good. It is metabolic acidosis plus respiratory acidosis. Correct? Everyone agreed. Metabolic acidosis तो था ही, because my respiratory PaCO2 is higher than what was expected. It is also respiratory acidosis. इतना clear है? Everyone is in sync with metabolic acidosis with respiratory acidosis. Everyone is clear with this? Clear हो? Clear है? Clear हो, right? Yes, whenever there is a metabolic acidosis, we have calculated Winter's formula. What is the next step? Anion gap. Anion gap निकालो. Patient का anion gap निकालो. Hagma है. Very good. It is 15. Yes, it is 15. Hagma है. Once there is 15 Hagma, what is the next step? Find out the delta ratio. What is the delta ratio? So we are going in step. First step was primary disorder, metabolic acidosis. Next step was निकालो Winter's formula से expected PaCO2. उससे क्या निकला? Respiratory acidosis भी है. Third step, अगर metabolic acidosis है, find out whether it's Hagma Nagma by anion gap. निकाल लिया Hagma है. चौथा step क्या है? Check out delta ratio. क्या है delta ratio? It is 3/13. Very good. यानी कि can I say that the change in bicarb is more than the change in anion gap? Can I say that 3/13 is ultimately less than 0.8 ना? Less than 1 ही होगा. Can I say that? Therefore, can I say that bicarb is being lost more than what it was supposed to be? So bicarb depletion किस में होता है? Change in bicarb मतलब bicarb loss is more than what it was supposed to be. बाइकार्ब डिप्लीशन कब होता है? कहां पे पढ़ा है हमने? हगमा में पढ़ा है या नगमा में पढ़ा है? बाइकार्ब डिप्लीशन हगमा या नगमा? हगमा या नगमा बाइकार्ब डिप्लीशन? निकाल के दो यार। बाइकार्ब डिप्लीशन हगमा में होता है नगमा में होता है? नगमा। अरे कौन हगमा लिख रहा है? नो नो बाबू, बाइकार्ब डिप्लीशन कैसे होता है हगमा में? व्हाट इज दिस स्लाइड दैट वी टॉक्ड ऑफ? व्हाट इज दिस स्लाइड दैट वी टॉक्ड ऑफ डियर? ये स्लाइड क्या है? ये स्लाइड क्या है? व्हाट इज दिस? व्हाट इज दिस बाइकार्ब डिप्लीशन? व्हाट इज दिस नगमा? है ना? इज दिस क्लियर? हाँ एग्जैक्टली। सो डिप्लीशन कहां पे हो रहा है? नगमा में हो रहा है। व्हाट इज द फाइनल डायग्नोसिस देयरफॉर? व्हाट इज द फाइनल डायग्नोसिस? इट इज हगमा प्लस नगमा. Final diagnosis is hagma plus nagma. Now, just let us recap this case. First thing was to find out primary disorder. Metabolic acidosis निकला. उसके बाद तो was to find out Winter's formula. Expected PaCO2 निकला. Respiratory acidosis भी है. यानी कि what do I mean by respiratory acidosis? Patient is hyperventilating या hypoventilating? Please don't give me wrong answers here. I'll be extremely disappointed. Respiratory acidosis का मतलब क्या है? Patient hyperventilate कर रहा है या hypoventilate कर रहा है? हाइपोवेंटिलेट कर रहा है. बहुत अच्छी बात है. कैन यू नाउ सी, कैन यू पॉइंट मी आउट वन वर्ड दैट इज देयर इन द हिस्ट्री ऑफ दिस पेशेंट दैट विल टेल यू कि ये पेशेंट क्यों हाइपोवेंटिलेट करेगा? कैन यू टेल मी वन वर्ड दैट इज प्रेजेंट इन द केस ऑफ दिस पेशेंट जिससे आपको पता चलेगा कि ये पेशेंट क्यों हाइपोवेंटिलेट करेगा? यस, ब्रेन ट्रॉमा. यस, वेरी गुड. इट्स अ ट्रॉमेटिक ब्रेन इंजुरी. करेगा ना हाइपोवेंटिलेट? रेस्पिरेटरी सेंटर डैमेज है, हाइपोवेंटिलेट करेगा, पीएससीओ2 बढ़ेगा. है कि नहीं? ठीक है, ठीक है ना? ठीक है, इतना क्लियर हो? ठीक है, ऑल ऑफ यू आर क्लियर विद दिस केस? ऑल ऑफ यू आर क्लियर विद दिस केस? किसी को प्रॉब्लम हुआ? नगमा क्यों नगमा है? किसी को प्रॉब्लम हुआ? सी, वंस वी फाउंड आउट इट्स अ डेल्टा डेल्टा रेशियो इज 3/13 व्हिच मींस change in anion gap is 3. It should have led to 3 change in bicarb, but 13 change हो रहा है, which means somebody is losing bicarb from the system. The change in bicarb is more, the loss of bicarb is more compared to what it should have been. 3 units should have been lost, but here 13 units are being lost, which means somebody is losing bicarb more. That is nagma. Clear? Clear? Clear हो इतना? Clear हो इतना? Clear हो? How much of energy do you have to do respiratory failure? दो ही स्लाइड्स है, सिर्फ 2 स्लाइड्स है. How much of energy do you have to do respiratory failure? I have a lot of energy left in me. आप लोगों के पास कितना है वो बताओ. I don't want to saturate you all. सबके पास है एनर्जी है? रेस्पिरेटरी फेलियर कर ले. सबके पास एनर्जी है? एनीवन हु डजंट हैव इट, कोई बात नहीं, आई विल अंडरस्टैंड. ठीक है, डन है, कर ले रेस्पिरेटरी फेलियर. 2 ही स्लाइड्स है, देखो सिर्फ ये स्लाइड है और सिर्फ हमारे पास ये स्लाइड है, बस दैट्स इट. बस यही 2 स्लाइड्स है हमारे पास. कर ले रेस्पिरेटरी फेलियर. एवरीवन गुड विथ मी? कैन वी डू रेस्पिरेटरी फेलियर टुगेदर? टिल नाउ अभी तक जितना मैंने बताया, अभी तक मैंने जितना बताया क्लियर है? अभी तक मैंने जितना बताया, I have completed everything about metabolic disorders. Is it clear? Good. चलो अब करते हैं respiratory disorders. Can I get a 10-second break? थोड़ा पानी पी लूं मैं. You all can also, get some water. Refresh yourselves up. Okay. I'll give you a couple of minutes. Freshen up. We'll start off with respiratory disorders. Basically, we'll just do respiratory failure, approach to respiratory failure. By the way, this slide that you are seeing, this algorithm is not my algorithm. It is an algorithm by, as I said, by my mentor, Dr. Dilip sir. So again, this algorithm is entirely his algorithm. And I found it one of the best ways to study respiratory failure, to be honest. Okay. Take a few seconds. Don't be saturated. Okay, are we good? Shall we begin? शुरू करें? Respiratory failure शुरू करें? Everyone's good? All back to the tables? All back to the tables? Back to your desks? Good. Good. Okay. Okay, good. So, let's do this. Okay. So when we talk of respiratory failure, we basically have 4 types of respiratory failure. However, in clinical settings, we usually talk of 2 types. What is basically the main component that differentiates a type 1 versus the type 2 respiratory failure is nothing but PaCO2. See, I'll be taking you to my first slide. ध्यान से देखो. Did I not say this? That number 3 and number 4, the only difference is respiratory acidosis matlab there's a lot of PaCO2. If PaCO2 is high, it is typically called a type 2 respiratory failure. Whereas in number 4, if PaCO2 is low, it is called a type 1 respiratory failure. Is this clear? Now, there are many authors or many school of studies which say that type 1 respiratory failure has a low PaO2 with a normal PaCO2. Now, why I disagree to this thought is, suppose a patient, I'm giving you a normal example of a type 1 respiratory failure, ठीक है? Somebody who is in high altitude, ठीक है? आप अभी लेह लद्दाख गए हो, you are in a high altitude. Do you agree that you will gradually have a hypoxemia? Agreed? Anyone who is not in sync with me? अभी आप लेह लद्दाख जाओगे यहाँ से, unless you are living in Ladakh currently. I hope there is no one right now who's joining this session from Ladakh. If you are, my heartiest greetings. You're joining in from one of the topmost altitudes of this country. But considering we all are living in the plains, अभी आप यहाँ से लद्दाख जाओगे, suddenly there will be a hypoxemia that you will be developing. There will be a low PaO2 that will be developing. True or false? True or false? Good. Can someone tell me why do we develop a hypoxemia in low altitude, in higher altitude? I'm giving you 2 options. चलो कोई option नहीं देता हूँ. Someone who can tell me why do we develop hypoxia in low oxygen concentration. This is a very interesting thing that you have said. What do you mean? Is it low PaO2 or is it low FiO2? Is it low PaO2? Is it low FiO2? No, it is not low PaO2. No, it is not low FiO2 either. Nope, not at all. I'm so sad to see this. No, it is not low P. Yeah, low PaO2 will develop due to hypoxemia. That's agreed. I'm asking, why is this low PaO2? Is it due to low FiO2 or is it due to what else? Low PaO2 to hoga. Of course, there will be low PaO2 due to hypoxemia. Why is this hypoxemia developing? That is what I'm asking. I do not know why somebody has written low FiO2. What is the FiO2 that is there? The air that we breathe in has how much percentage of oxygen? 21. So do you think this 21% oxygen is different? मतलब अब कनाडा में 23 है, ग्रीनलैंड में 35 है, इंडिया में 21 है, ऐसा कुछ है क्या? या फिर इंडिया में भी राजस्थान में 16 है, मदुरई में 25 है, कश्मीर में 59 है, ऐसा कुछ है क्या? Do you think that when you go to the southern states you breathe more oxygen? How are you saying it's low FiO2? No man. Whenever you are in a high altitude, FiO2 never changes. In fact, आप किसी भी डेप्थ में चले जाओ, किसी भी हाइट पे चले जाओ, FiO2 will remain 21. You know what changes at the height? It's the barometric pressure changes. It's the barometric pressure which changes that leads to hypoxemia. So the low PaO2 that you have in a higher altitude is due to low barometric pressure. हवा थिन होता है ऊपर, जितना आप ऊपर जाते हो ना लेह लद्दाख की तरफ पे, the density of air becomes thinner. When the density of air becomes thinner, the barometric pressure decreases. Whenever the barometric pressure reduces, what happens is that causes the hypoxemia. Is this clear? कभी भी लाइफ में आगे से नहीं बोलोगे promise me you will never ever say this, that in higher altitude hypoxia is due to low FiO2. Please मत बोलना, please. Promise this to me. Promise. It's a promise that we make today. Chalo, high five. It's a promise we make today. Higher altitude does not have hypoxia due to low PaO2, does not have hypoxia due to low FiO2. FiO2 stays consistent throughout every place on this earth. FiO2 is going to remain the same. It is 21%, 21%, 21%. The air we breathe in has 78% nitrogen, 21% of oxygen. Itna clear hai, har jagah pe clear hai. What I am telling you is, at higher altitude, hypoxemia develops due to, yes. So Dr. Kranti Naidu, absolutely correct. It is the lesser barometric pressure which will reduce the alveolar PO2. अभी मैं alveolar gas equation पढ़ाने वाला था, but once I teach you that, you will realize that it is the low barometric pressure which reduces the alveolar PO2. Because the alveolar PO2 reduces, naturally the arterial PO2 also reduces. So P capital AO2 reduces, thereby leading to a decrease in the P small AO2. ठीक है? Is this clear? Is this clear, everyone? Now my point is, whenever someone in Ladakh is having a low PaO2 और वो आपके इमरजेंसी पे आता है, आप उनका PaCO2 पहले चेक करोगे या उनको ऑक्सीजन डालोगे? या फिर आप सोचोगे कि नहीं, डॉक्टर नवोनिल ने हमें पढ़ाया है कि अभी रेस्पिरेटरी फेलियर पे जा रहा है पेशेंट, पहले देखूं मैं टाइप 1 है कि टाइप 2 है. बिफोर यू मेजर, टेक द ब्लड फॉर चेकिंग PaCO2 लेवल्स, विल यू कीप द पेशेंट कि नहीं आपका सैचुरेशन गिरता रहे, आप मर जाओ, कोई फर्क नहीं पड़ता मुझे, या फिर विल पुट द पेशेंट ऑन एटलीस्ट एन NRBM? डालोगे ना, NRBM डालोगे ना, या फिर एक फेस मास्क डालोगे ना, कुछ तो डालोगे, NRBM डालोगे, फेस मास्क डालोगे, कुछ तो डालोगे. गुड. तो वंस यू गिव अ फेस मास्क ऑन ऑक्सीजन, 2 लीटर पे हो, 4 लीटर पे हो, 6 लीटर पे हो, डोंट यू थिंक दैट द PO2 विल नॉर्मलाइज? Don't you think that the PO2 will normalize? So when I talk of type 1 respiratory failure, low PaO2 is not an essential component, because most of these patients will come to the ICU, will come to the emergency, and they'll be immediately put on oxygen. यार आप सांस ले रहे हो, ऐसे करके सांस ले रहे हो, तो मैं आपको ऑक्सीजन पे डालूंगा या ब्लड चेक करूंगा PaCO2 के लिए? नहीं करूंगा ना. Now, because in high altitude there is hypoxia, hypoxia stimulates the peripheral chemoreceptors to start hyperventilation. Because of hyperventilation, what is hyperventilation? This CO2 is washed out. That is what causes the low PaCO2. So type 1 respiratory failure is characterized by low or normal PaCO2. Type 2 respiratory failure is characterized by high PaCO2. Is this clear or not? Clear or not? Good. So this is the difference between type 1 and type 2. What is type 3? Type 3 is basically due to post-op atelectasis. Type 4 is something that we see in shock states, where the perfusion of the lungs in itself is critically compromised. That is type 4 respiratory failure. But I'm not going to delve well deep into type 3 and type 4. Type 1 and type 2 is what I wanted to say. The only marker that differentiates type 1 and type 2 is PaCO2. PaCO2 high hai, to type 2 hai. Normal hai, low hai, to type 1 hai. Khatam. Is this clear? Is this clear? Sab clear hai? Very good. Now, whenever we have a suspected case of a respiratory failure, our first step is to check for PaCO2 levels. As I said, first step, check for PaCO2 levels. You can either have a decreased PaCO2. If it's decreased, we call it a type 1 respiratory failure. That is the left side of this segment. And if it's an increased PaCO2, we call it a type 2 respiratory failure. But in either of the cases, the next step, whether it's a type 1 or a type 2 respiratory failure, the next step is to check for AA gradient. That is alveolo-arterial gradient. Alveolo-arterial gradient. What is alveolo-arterial gradient? It's P capital AO2 minus P small AO2. ठीक है? अब P small AO2 का वैल्यू तो मुझे ABG में ही मिल जाएगा. Every PaO2 value that is given in the ABG is nothing but P small AO2. How to find out P capital AO2? That is given by the alveolar gas equation. And what is the alveolar gas equation? It is FiO2 into P atmosphere minus P barometric minus PaCO2 by RR. बहुत simplify करते हैं इसको. Atmospheric pressure is 760 millimeter mercury. Barometric pressure is 47 millimeter of water. which makes it 760 minus 47 कितना होता है 713. So 713 into FiO2 minus PaCO2 by respiratory quotient कितना है 0.8. So the formula becomes 713 into FiO2 minus PaCO2 by 0.8. Khatam. Is this clear? This is basically my PaO2, P capital AO2. This minus P small AO2 जो कि मेरा ABG वैल्यू पे दिया रहेगा. The difference of this is what will be my next step to see. Is this clear? Is this clear? Is this clear, everyone? First, please, or fast, please. Whatever. What are you saying? Are you telling me to be fast, or are you telling me to repeat? Repeat. Okay. देखो, FiO2 into P atmosphere minus P barometric. What is P atmosphere? 760. What is P barometric? 47. 760 minus 47 करो कितना होता है 713. 713. So the formula becomes 713 into FiO2 minus PaCO2 divided by 0.8. Respiratory quotient is 0.8 for a standard meal that we take. Clear? Clear है? Karthik, is this clear? Good enough. Okay. Now, normally your alveolo-arterial gradient should be less than 12. But if it is more than 20, if this gradient is increased, this side, if the gradient is increased, that is more than 20, in a type 1 respiratory failure. So I am repeating, suspected respiratory failure comes to you, check PaCO2. PaCO2 is normal, it is type 1. In a normal PaCO2, that is type 1 respiratory failure, next step is A gradient. If the A gradient is increased, it means there is some intrinsic problem inside the lung. Lung में कुछ problem है. That we'll be seeing what it is. If the A gradient is normal, यानी कि less than 12, it clearly means that despite having a low PaCO2, you are still having a respiratory failure. इसका एक ही कारण हो सकता है, या तो FiO2 is low or P barometric pressure is low. Can I say this? आपका AA gradient is normal, यानी कि एल्वियोलस में भी ऑक्सीजन काफी मात्रा में है और एल्वियोलस से डिफ्यूजन भी सही तरीके से हो रहा है. सी दिस एल्वियोलस के अंदर इज P कैपिटल AO2, दिस कैपिलरी में आर्टरी में जो है दैट इज P स्मॉल AO2. अगर PaO2 and P small AO2 is normal, यानी कि A gradient normal है, can I say alveolus is fine, artery is fine? Can I say that the alveolo-capillary unit is perfectly fine? Can I say that? Can I say that? अगर AA gradient normal है, can I say that alveolus भी fine है, capillary भी fine है, diffusion भी fine है? तो प्रॉब्लम दो ही जगह हो सकता है, या तो बंदे ने बहुत ऊपर गया है, barometric pressure घट गया जिसके लिए PA became low, which is the what we find in high altitude, और FiO2 is low. FiO2 कब लो हो सकता है? एक पेशेंट आईसीयू में भर्ती है, आईसीयू में जो ऑक्सीजन सप्लाई है, द मेन सेंट्रल ऑक्सीजन सप्लाई, दैट इज ओनली डिफॉल्टी, या फिर सम फैट नर्स इज स्टैंडिंग ऑन द यू नो द ट्यूब ऑफ द वेंटिलेटर, और अ फैट पर्सन इज स्टैंडिंग और सिटिंग ऑन द ट्यूब ऑफ द वेंटिलेटर, या फिर देयर इज अ ट्यूब ऑब्स्ट्रक्शन, लोकल कॉजेस जिससे FiO2 घट रहा है. आर यू गेटिंग मी? Are you getting? Okay, yeah. So I'm trying to say this, that either a fat nurse is standing on the ventilator tube, or the ventilator tube has been ऐसे मुड़ गया है, या फिर there is an obstruction that is going to cause low FiO2. Is this clear? नहीं तो बंदा बहुत ऊपर चला गया है, higher altitude, जहाँ पे P barometric pressure is low. Is this clear? Can I say that this is the basic approach to a type 1 respiratory failure? Can I say this? Now, whenever there is a, now I'll be gradually taking you to this segment. So whenever there's an intrinsic problem, yani ki the AA gradient is very, very high, the first thing that I need to check is the patient coming to me by walking in the OP? If the patient is coming to me walking in the OP, I will see whether there is a desaturation with exercise. If the patient is having a desaturation with exercise, it clearly means that these patients have a low DLCO. And low DLCO का तीन ही condition है. An obstructive disease with a low DLCO is emphysema. A restrictive disease with a low DLCO is ILD. And a pulmonary vascular disease with a low DLCO is pulmonary hypertension. Agreed. If this patient is not desaturating only with exercise, yani ki this patient is also desaturating in normal conditions, yani ki now this patient has come to me in the ICU, my first step is to give a trial of 100% oxygen. Usually most patients will respond to this, yani ki the PaO2, the arterial PO2 will rise above 60 with a trial of 100% oxygen. And hence, the diagnosis of these patients become a VQ mismatch, a ventilation perfusion mismatch. Either this patient has a ventilatory defect, जहाँ पे ventilation was low, चाहे वो obstructive cause के लिए हो, restrictive cause के लिए हो, or the perfusion was absolutely low, like maybe there's a pulmonary embolism, maybe there's a shock that is there which has led to hypoperfusion of the lung. And my treatment is just to treat the underlying cause. That's my only way to treat this patient. But if this patient does not respond to a trial of 100% oxygen, does not respond, which means now the oxygen that I'm giving is being shunted out somewhere, which means now this is what is a diagnosis of a shunt. A patient who is having type 1 respiratory failure, not responding to a trial of 100% oxygen. Yani ki the saturation is not improving, the PaO2 is not improving. This is what is the basic definition of a shunt. Shunt can be either anatomical, jahan pe in cases of TOF, that is like most common cyanotic congenital heart disease, we have pulmonary AV malformations. Nahi to we can have a physiological shunt. Physiological shunt matlab the lungs are too damaged. Ya to bilaterally there has been so much fluid that has been accumulated in the alveoli, so much pus accumulated in the alveoli, be it effusion, be it pneumonia, or so much of blood that has accumulated in the alveoli. More than 50% of the lung is either filled with blood, that is diffuse alveolar hemorrhage, or with fluid, that is pulmonary edema, or with pus, that is pneumonia. So much so that the ventilation is absolutely zero. So whenever I talk of a shunt, I am predominantly meaning a VQ equal to 0. So ventilation is 0 only in a condition which is called shunt. Either this shunt can be anatomic or physiologic. When I talk of physiologic shunt, it either can be a condition where more than 50% of the alveoli are either filled with blood or filled with pus, or it is filled with fluid. Or I have another case that one part of the lung majorly has either been, one segment of the lung has been completely collapsed, or there is a pleural effusion, or there is a mass effect on the lung which is completely obscuring the function of one of the lungs. Either of the scenarios, the ventilation in both these cases are going to be 0. And that is exactly what I've told in this slide. Either you'll have an alveolar filling defect where you have diffuse alveolar hemorrhage, that is maximum of the alveoli filled with blood, or pneumonia, maximum of the alveoli filled with fluid, or you will have a pus, or you will have a pulmonary edema, be it cardiogenic or non-cardiogenic, where maximum of the alveoli will be filled with fluid. Or you might be having a shunt with a white-out appearance of the lung, where either there is a collapse, unilateral collapse of the lung, or there is a unilateral heavy pleural effusion, or there is a constriction or a mass effect that you will be having because of a consolidation or a mass. One part of the lung is completely constricted, thereby leading to a condition called shunt, wherein ventilation is absolutely 0. Whenever you get such a case, the next step is to do a positive pressure ventilation. If the GCS of the patient is low, less than 8, if the patient is hemodynamically unstable, go with endotracheal intubation and invasive positive pressure ventilation. If either of the two are not there, and the patient is hemodynamically stable, GCS is okay, zyada secretions nahi hai that might lead to aspiration, then go with a NIPPV, that is basically a BiPAP or a CPAP, basically a non-invasive ventilation. That is how you manage a type 1 respiratory failure. Type 2 respiratory failure is extremely simple, because in a type 2 respiratory failure, your concern is nothing but to see, number one, the PaCO2 is high. Whenever the PaCO2 is high, it clearly means that it is a case of type 2 respiratory failure. And once it's a case of type 2 respiratory failure, your next step is to go with an AA gradient diagnosis. A gradient अगर normal है, then it clearly means that the alveoli is hypoventilating. What do you mean by ventilation or minute ventilation जिसको हम बोलते हैं? What is the formula? It is tidal volume into respiratory rate. If the alveoli is hypoventilating, it means either tidal volume is low because the patient is not able to breathe in air, which can occur due to neuromuscular weakness, neuromuscular disorders, motor neuron diseases, polio हो सकता है, ALS हो सकता है, or it is a low respiratory rate. As I said, alveolar ventilation is equal to tidal volume into respiratory rate. Tidal volume low, patient is not able to breathe in, or respiratory rate is low because there is a damage to the respiratory centers, maybe a brainstem injury, a brainstem dysfunction, maybe some drug overdosing lead to depression of the respiratory centers, maybe an increased intracranial pressure that is leading to decrease in the respiratory rate of the patient. That is all that you get in cases of respiratory failure. And the difference between type 1 and type 2 is, if it is a type 2 patient, you can again go with endotracheal intubation if the GCS is low and hemodynamic is unstable. But if the GCS is fine and hemodynamics is fine, you can use non-invasive ventilation, but never a CPAP. Always remember, CPAP is contraindicated if PCO2 is high. You will either go in for a BiPAP, or you will, if you want to do an invasive endotracheal intubation, you will go for an invasive ETT. That's exactly how to approach a case of respiratory failure. Am I clear? With this, we come to an end of this discussion. I have tried, putting up all the possible case scenarios that we could have done. I've tried putting up, the major areas that we are supposed to focus in the ER, and I hope you had a very good session. Okay, there's somebody who's asking why CPAP contraindicated. Okay, so whenever there's a high PCO2, what happens with the CPAP? So the mechanism of CPAP is to keep on delivering continuous positive airway pressure. It will never be able to sync with the patient's respiratory rate and the breath, which is why in PCO2, it is in a case of high PCO2, giving a continuous positive airway pressure at the cost of a hypoventilation leads to alveolar dysfunction. It leads to bursting of the alveoli. It leads to trauma to the alveoli, which is why we avoid CPAP in cases of type 2 respiratory failure. Okay? You'll be learning more about this once you start knowing about the ventilator basics and mechanics. I'm very sure we have a critical care team expert in Mediversal, or maybe I'm very sure we have some courses even on ventilator mechanics and critical care. That definitely will be taken up. I can talk of ventilators, but then I am not the best person, because I would always leave it to the anesthetist or maybe somebody who is well versed with how ventilator mechanics work. But this is the brief outside that I could have given you. Now, at least when you step into an ER or an ICU, when you see an ABG report, you will probably not be baffled. So learn the algorithms that I talked of, think of it, and keep seeing more and more number of ABGs. The more and more number of ABGs that you will keep seeing, you will start getting that confidence that, okay, I will need to apply this algorithm. And keep in mind the algorithms that I talked of, because these algorithms are the ones that will keep on making you have a very clear head. Up mixed up nahi honge. You will not be confused. The more number of cases you see, the better you will start being in reading an ABG. At the end of the day, it's just a piece of paper. But trust me, if you analyze an ABG well with the clinical parameters of the patient, don't just look at it as just a piece of paper. Look at the clinical parameters of the patient. That is something that will always guide you into making better choices for the patient, and also uplifting yourself and upskilling yourself as a physician. So I hope I could give you a good insight. I'm so glad to all of you who have joined in, and I'm really happy that I could spend this time with all of you, and I'm really glad with all your responses. You have been extremely extremely pleasing an audience, a very well mannered audience, a very lively audience, and a very enthusiastic audience, to say the least. So thank you so much for being there and uplifting me for a webinar like this. Thank you so much. I would want Vijay sir to take over.
Thank you, doctor. Thank you so much. It was again a great session, like always. Whenever you take sessions, we always the depth of the topic would always be taken care. Thank you so much for the session. I'm pasting the certification registration link on the chat box. Please, doctors, go fill the form to get your certifications. The certificates will be sent immediately after clicking submit button. If you have not got in your email inbox, please do check on spam folder. I would request everyone to submit the form properly. Check your internet before submitting. That one request I would do, and I'll be here for 5 more minutes for your. I don't think there will be any questions as such, doctor, because I know you have been cleared each and every questions as and when it happens. I don't
Yep.
think, but still, for formality we are opening the Q&A session. But I
Sure.
personally think there will be no questions. I think there are no questions. Yeah, doctors, I'll be here for 5 more minutes. Please do
Yep.
fill the form for to get your certificates. And if you want to talk anything about the session, you can raise your hand. I will. If you want to give
Yes,
your
I would
feedback,
love to read your reviews on this session. As
yeah,
Vijay sir says, uh, in your forms, I would want you to be brutally honest. I want you to talk of areas where I can improve, probably where we can improve as a team, and where where we can all become better people and better physicians. So I'm open to being criticized and being analyzed in any way that you wish to. Uh,
yeah.
but this
Raise your
is
hands. We can also permit you to unmute yourself if you want.
Yeah, if anyone wants to talk of the session, you're more than happy to unmute yourself and maybe talk on this. I'll be very glad.
I think there are no such requests. Fair. We can wind up the day, doctor. The session was really
Yeah,
great. Thank you so much for. Uh,
thank you so much, and thank you to the entire team of Mediversal again for being there and for taking up these topics, which indeed at times I feel are the need of the hour. This is
yeah,
one topic which I have been trying to get done since a very long time
very
now, as
long
I
time.
said
I
in the
remember. I remember.
beginning, and I'm so happy that I could get this done with all of you. And
There's one particular comment I want to read it out. We'll
yeah,
always remember Dr. Navonil whenever we read about ABG from now on.
thank you so much. That means a lot. It really means a lot to me. If I've been able to create even a little mark in your lives going forward, it will be something that I will hold very, very close to my heart. So thank you, whoever it is, doctor. It means a lot to me, and I hope you stay well. You hope you all stay well, and I hope you keep joining in the webinars, and I hope you all keep supporting me and loving me the way that you do. It's been an absolute pleasure. Thank you so much. It's a weekend. You've still spent so much amount of time with me. I know it's dinner time for most of you, so I put my regards to all of your family members, and I hope you have a very, very, very wonderful new year ahead. Stay blessed, stay happy, and stay healthy.
Thank you. Thank you, doctor. Thank you so much. Thank you.
Thank
Uh,
you.
Thank you. Good night. Good night, all. Happy weekend.
Thank you.
Thank
Thank you
you.
so much.
Okay.
Thank you.
Sure, sure. We have a lot of sessions planned up for Dr. Navanil. Don't worry. The sessions are lined up. Thank you.
I'll also request you all. I'll also request you all. This is just something which I wanted to say from my end. Please keep following the Instagram ID of Mediversal Academy. There's also a parallel case series that I keep posting. Right now we are in case 136,
34. Today
144.
134 has posted. Yes.
134, yeah. So we are in case number 134 right now. It's a parallel case
Yeah.
series that I've been posting for quite a while now, where I've been trying to talk of interesting cases, either some which are presented to me in my hospital or a modification of those cases, where I've tried to talk on important topics. It's just like an Instagram shorts. Maybe it's a 2 to 3 minute video, max to max a 5 minute video in some cases. Otherwise, it's usually a 2 to 3 minute video on the case, why it posed some diagnostic challenges to us, or what we were looking at it from our clinician's viewpoint. It's something that I try posting every week, so that you can stay in touch with it, and we can also stay connected in that way. So not just me taking webinars. I want you all to know that that is also one way that we all can stay connected. Pour in your comments whenever a case drops in. Even if it's the right answer, wrong answer, just doesn't matter. We are all here to learn. And maybe someday your questions will make me learn something more from you as well. So please be connected. And I think Vijay sir, you can share one of the links of the
I
case
have
series.
already done it. I have done it. Case
Okay,
31,
fantastic. Yeah,
34
so
link has been shared.
I think you can take a look at those, and you can pour in your love, you can pour in your criticisms as well. I'm saying this is an open platform, perfectly. Every one of your reviews will be read and will be taken care of. That is something which I can assure you. So thank you all. Have a very good night, and stay blessed. Have a very good Sunday tomorrow.